opioid epidemic at our first International Congress. Kind of the godfather of opioid-free anesthesia is a Belgian anesthesiologist named Dr. Moulier, and I got to meet him and listen to him talk. And he gave a pretty fantastic, comprehensive history of opioids. His lecture was actually about an hour of it. But taking from that, kind of the highlights, the Sumerians were cultivating poppies back in 3000 BC. That's as far back as there's documentation of it. Alexander the Great actually spread it across Europe, Middle East, and the Indian subcontinent. And then the concepts in healthcare of addiction, abuse, and tolerance were described in literature all the way back in the 16th century of the Middle East and China. So long history there of even documentation of the side effects. And then fast forward to more recent history, the drug companies, since the 1920s, have marketed the next opioid analgesic as the tamer form of opium and the way to go. So they definitely have a systematic pattern with their marketing. Again, future, fast forward to more recent history. The British actually fought 2 wars over opium with China back in the 1800s, and that was fought to keep the opium trade open and the revenue generated from it flowing. In the Civil War times, opioid addiction was then termed a soldier's disease. And then at the turn of the 20th century, the Bayer acetylated the carbon ring of morphine to form heroin. The medical studies back then actually showed that heroin reduced the death rate from opioids by an absolute margin of 2.4%. Had to do a little bit of digging to figure out what that is, but to frame it in practical terms, that if there was a drug that was brought to market today in healthcare, if it reduced the death rate just by 1%, that would change the pharmaceutical stock market overnight. So to think that heroin did that to morphine back then, about 2.4%, would just have totally revolutionized what the side effects were back then. So, and then again, we talked about every other opioid marketed as the safer, non-addicting alternative. Those newer drugs since then include Demerol, oxycodone, hydrocodone, methadone, and OxyContin, among others. So definitely have issues with all the others as they've come about, but I don't think with the history of them, they've proven to actually be the safer, non-addictive alternatives. So in the more recent history, there are really 2 items in the medical literature since the 1980s that have really lit the fuse on opioid use. Prior to the 80s, opioids were really only used to treat acute pain, and that's because most physicians feared the addiction and overdose risks. But then in the 1980s, we got Vicodin, and from a societal policy standpoint, we also had the Just Say No to Drugs campaign with Ronald Reagan's terms. And at that time is when physicians began to explore opioids as the treatment for non-acute pain. So we can't really do a show of hands because we're not live, but how many, at least I was always taught in both my undergrad nursing as well as my graduate CRNA studies, that the rate of opioid addiction is less than 1% for patients. That's something I remember hearing distinctly and quoted, but I always wondered where that came from. So it turns out that comes from a edition of the New England Journal of Medicine in the 1980s. Only downside to that statistic is it came out of a 5-sentence letter to the editor, and that concluded that the rate of addiction was less than 1%. This was not a randomized study, wasn't prospective, nothing. These guys that did this letter to the editor simply looked back at their paper records and looked and saw that if the patient was labeled an addict, that was a positive identifier. If it didn't say addict, then by definition, their definition, you weren't actually addicted to opioids. There were no controls, no further methods, just the retrospective chart review looking for the word addict as part of the diagnosis list. So, knowing that it's 5 sentences and a total of 100 words in the letter to the editor, what impact did that have on lighting the fuse of the opioid epidemic we currently find ourselves in? Well, some researchers actually took a look at that, and 2017 published this analysis of the effect of that letter on medical research. You can see how many times that letter has been cited as a evidence that opioids are not addicting. So to put this one in perspective, this letter was cited 55 times more frequently than any other letter to the editor that was in the New England Journal of Medicine from the same time. It just ran rampant. So the actual totals for that was in 37 years, 608 total citations, 439 were cited as evidence that it's not that addiction was rare. And then you can see kind of a spike around 1995 or in 1996, just after OxyContin was introduced. So part of the marketing that came with OxyContin was citation of this as evidence, as opposed to poor retrospective chart analysis. Then there was a second article that came out by this Dr. Russell Portnoy, and it looked at 38 cases. And if you've done much of the research validation, his methods were questionable at best. So he looked at 38 patient retrospective analyses. Now, he's a neurologist in New York and has a very busy pain practice as a neurologist, but somehow he selected 19 patients out of a busy practice and combined them with 19 patients that were included in a PhD dissertation of a similar focus. So the method sections of this article have no discretion on how those patients were selected or any of that. So very poor methods. And of these 38 patients, he found them to fall into roughly 3 groups. A third had no pain relief from chronic opioid use. And the 2/3 that received pain relief, half of those patients, so 1/3 of the total population, required dose escalation over time, which in modern terms would be defined as tolerance. So looking back and actually having read this paper now, I would wager that this would be laughed out of submission in today's medical literature. But unfortunately, in 1986, it made it in. So anyone who is a numbers geek also knows that you, like myself, you cannot define safety and efficacy in a retrospective manner. You actually have to do this prospectively from a methodology standpoint. So, but in a twist of fate, it was published, and Dr. Portnoy is actually quite charming and articulate in person. I've seen him on video interviews, and he then hit the lecture circuit claiming that the opioids are, quote, this is a quote, are a gift from nature, and that they're being wasted on humanity because of opioid phobia. So he was quite vocal about this, and he's made it his life's work to destigmatize opioids for providers. However, all the wonderful benefits that he conveys with the opioids, in his own study, he found that there were few substantial gains from employment or social function in starting opioid therapy, but that is also, he concluded, is a safe and more humane treatment options compared to surgery or no treatment in intractable non-malignant pain without a history of drug abuse. So quite a few qualifiers there. So number one, what if, and speaking from an anesthesia provider perspective, what if opioids aren't really safe? What if we've gotten so far off the rails when these were introduced that we've just gone along with the narrative that they're safe safety profile and effectiveness is actually just a echo chamber of these two people and these two articles. And the thing that kind of haunts me is, what if we just accepted opioid-based anesthesia as the best of the bad options? So looking more at this Russell Portnoy guy, he's credited as the mastermind behind the concept of opioids in chronic pain management. As I said, he's a neurologist. He works at Beth Israel Medical Center in New York City. He's the chairman of the Department of Pain Medicine and Palliative Care. He's also the director of the American Pain Foundation, past president of the American Pain Society, and he's a consultant to more than a dozen pharmaceutical companies at the same time. And the pharmaceutical companies that have him as a consultant should be fairly familiar names. A couple of them are Endo, Abbott Labs, Kefalon, Purdue Pharma, Janssen, Johnson & Johnson, Teva Pharmaceuticals, as well as several others. So those are well-named known pharmaceutical companies to at least us in the anesthesia world. So quite an impressive resume for him. So how did we get to where we're at? Well, everybody's heard that pain is the fifth vital sign. The American Pain Society is the one that came up with that idea, not JACO, as everybody likes to say. JACO used it as a reference, but it was actually the American Pain Society that came up with that. Dr. Portnoy was the president of that, if you remember from the previous slide. The American Pain Foundation also lobbied regulators to have a more aggressive treatment of chronic pain. Dr. Portnoy was the director of that society as well. The pain as the fifth vital sign was also endorsed by the American Medical Association. And so we got pain as the fifth vital sign. OxyContin was introduced in '96, and again, marketed as a safe alternative. And part of their marketing was it avoided the peaks and troughs of the plasma levels of the narcotic, and therefore avoided the euphoria and the tolerance issues. So altogether, these manufacturers and societies and the industry, quote unquote, experts, were able to create an implied consensus that this was the right way to go. And so the two societies that Dr. Portnoy was in charge of put out a position statement that said using long-term opioids to treat non-malignant pain carried little risk for addiction or overdose. Again, mostly based off of his study and then the other one in the New England Journal of Medicine. So a little bit of a conflict of interest there if you're looking for full disclosure. So this thrust and shift in policy and methodology then further led regulators and the accrediting bodies to promulgate poor incentives based off of poor data. A couple other things I found when researching this topic, these were quotes out of the different things. In 2000, in JAMA, author Phillips was quoted as saying, excuses for the inadequate pain control have run their course, will no longer be accepted because it's clinically unsound and economically wasteful. Other stuff in the literature at the time, there's the National Pharmaceutical Council that said, patients in pain do not become addicted to opioids, although the actual risk of addiction is unknown. It's thought to be quite low. And that the fear of a provider about a patient becoming addicted comes from a lack of understanding of the risk of addiction and therapeutic drug use. And that risk is often overestimated. So if you read between the lines of this, if you have policymakers, industry experts and everything, you can see how an individual provider that's taking daily care of patients might get the sensation of, if all these people are saying this, I must be at fault. I don't understand this. This is what I should be doing. I should probably get on board. And so all of these perfect storm of messages to individual providers over the last 40 years came together to get us into the position we're at. So JACO then, back in 2001, also framed pain management as a patient's rights issue. They actually put out a guidebook that stated there's no evidence that addiction is significant use when persons given opioids for pain control. That guidebook was sponsored and paid for by Purdue Pharma, the makers of OxyContin. So interesting how all of these pieces of the web weave together. In 2004, the Federation of State Medical Boards, they urged licensing bodies in each state to punish providers and hospitals for not treating pain adequately. This policy was drafted by Dr. David Haddocks, who is a senior executive at Purdue Pharma as well, the makers of OxyContin. So, and then since 1997, those state medical boards have received almost $2 million in donations from opioid manufacturers. So fast forward to Dr. Portnoy. He further went on to say in one of his interviews that, and this is a quote, "My viewpoint is that I have those relationships and they would benefit my educational mission, they would benefit my research mission, and to some extent they can benefit my own pocketbook without producing any tendency to engage in undue influence or misinformation." If you're on the payroll of a dozen pharmaceutical companies, I don't know how you can say that with a straight face, but it is quoted as out there. So what if number two? And I am not a conspiracy theorist, but I believe that based on this and some other stuff we're going to cover here in the coming few minutes, that the case can be made that this should never have occurred. So what if we've all been duped? What if we got, sidetracked years ago and this has just perpetuated itself to where we find ourselves today? Kind of what if we've all been sold a bill of goods at the expense of hundreds of thousands of lives lost and a society in crisis? It's kind of overwhelming when you look at it from this angle. So the rest of the story. If you're interested more in the history of this, there are, I think, about a dozen documentaries now. They're on PBS, YouTube, and there's actually a Sundance Film Festival documentary that looks at the Sackler family. And the Sackler family is currently one of the richest families in the country, according to Forbes. These three guys here were all executives at Purdue Pharma, the makers of OxyContin, owned by the Sacklers. And these three guys pleaded guilty to misdemeanor misbranding when it comes to OxyContin. The three guys in order is their attorney, their medical director, and the president of the company at the time. So collectively, the Purdue Pharma paid $600 million in fines for the misdemeanor misbranding, and then these three individuals paid a combined $34.5 million in fines. So how does that stack up? Well, since 1996, Purdue Pharma has had $35 billion in sales of OxyContin. So the fines that they paid equated to roughly 1.7% of the total sales from OxyContin. So when you put that in perspective, a $635 million fine is more or less the cost of doing business for them. And then in a time frame, the Sackler family from 2008 to 17, since this misdemeanor misbranding case, has had another $10 billion in profits. So just as of 2 months ago, with this settlement with the opioid crisis, they've increased a payout. Oh, I got to go over the slide first. Hold on. So pursuing this further criminally, the New York Attorney General also found that the Sackler family offshored about $1 billion that was previously undisclosed as part of the liability cases that are pending against them with the opioid epidemic. And then also back in September of 19, they filed for Chapter 11 bankruptcy. They did this because that automatically prompts a stay of litigation against the company, because at the time they had 2,600 lawsuits pending against them related to the sale and use of OxyContin. So they filed for bankruptcy, which puts all those cases on hold and settles most of them. And then with this, the Chapter 11, it'll dissolve Purdue Pharma and form a new pharmaceutical company to continue manufacturing the other drugs that they make and to pay the damages. However, the damages paid out to victims are going to be from the continued sale of OxyContin, which is just mind-boggling to me. So the Sackler family's estimated net worth is about 13 billion. And then so in a 10-year period from 2008 to 2018, they had another 10 billion in sales in OxyContin. And then just in about 2 months ago, this lawsuit that they had originally agreed on was 3 billion over 6 years has now been increased to 4.2 billion over 9 years. So if you do the math, if you have $10 billion invested as a family and you get a roughly 8% return on that, your 10 billion after 10 years roughly doubles to 19.9 billion. So the Sackler family over a 10-year period is only going to be paying out half of the investment gains on the original principal that they had from the sale of OxyContin. Again, mind-boggling numbers that they can pay for those damages just out of the invested revenues in the market. So currently, Dr. Portnoy and some of the other pharmaceutical companies are also under investigation by the Senate Finance Committee, and more details to come on this scenario, but it's something to watch in the news. Every once in a while I see it pop up on different news feeds and whatnot. I was like, oh, another point to add to the lecture to keep it current. So anyway, moving on. We're going to move on to physiologic side effects. So we all know, sedation, hallucination, respiratory depression, PONB as common side effects from the opioids. But in total, the number one cause of emergencies in PACUs are actually defined as compromised respiratory function, which no doubt opioids play a large contributing factor to. Some of the lesser known negative physiologic side effects we look at are opioid-induced hyperalgesia, which is a very real thing, surgical hyperalgesia, chronic post-surgical pain, and then also some of the newer studies coming out is what do opioids do to the immune and endocrine systems. You actually get killer T cell suppression, which inhibits cancer treatment. You also get cortisol inhibition, testosterone deficiency, as well as osteoporosis from long-term opioid use. So if you look at UpToDate, which is something I turn to when I've got a question that needs current answer, it's a fantastic resource. They actually have an article titled Prevention and Management of Side Effects in Patients Receiving Opioids for Chronic Pain. So looking through this, it's a 28-page summary, and then attached to that is a 15 pages of reference and 9 pages of appendices, all to look at the side effects from opioids. In this, the article starts off that saying opioids represent a mainstay for the treatment of severe and chronic pain with active cancer and other serious chronic illnesses. It goes on to say that although the side effect liability, now keep in mind, this is a 28-page summary of the side effects. Although they have a side effect liability, these drugs are significant and they are inherently associated with serious problems of abuse and addiction that experience can potentially lead them to be used safely and effectively for all types of pain. Now, if you have a 28-page document detailing the side effects, you would think that maybe there's something more there, but that doesn't stop them from leading off the article with the statement. So, looking closer, this article in UpToDate is authored by Dr. Portnoy himself, the guy who's perpetuated a lot of our current situation. So even with some of the most reliable medical references, there's still insidious influences that can filter into it. So looking specifically at endocrine effects, this gets kind of down into the weeds of physiology, but it affects the HPG axis. The opioids bind to the hypothalamus, inhibit release of gonadotropin, releasing hormone, reduces luteinizing and follicle stimulating hormone. This results in clinical hypogonadism, or it actually has its own term in endocrinology as if it's a result of opioid treatment, and that's opioid-induced androgen deficiency. This effect can actually be seen within 24 hours of opioid administration. It is not something that develops over months to years. Hypogonadism, clinical effects, sexual dysfunction, infertility, fatigue, and mood disturbances. So this opioid-induced androgen deficiency, when they're specifically looking for it, actually is shown up in 90% of males on chronic therapy. And in women, it's thought to be severe enough that it will cause long-term amenorrhea, so reproductive issues if you're of childbearing years and interested in having a family. This could be negatively affecting that and preventing it. A few more endocrine effects. It also affects the HPA axis. So the opioids inhibit the cortisol releasing hormone, reduces the pituitary responsiveness to that. And then also it affects prolactin, which accelerates bone loss and leads to osteoporosis. And the prolactin also causes an increase in formation of breast tissue, and it interferes with some of the hormones of reproduction. So moving on to immunological effects, it's also immunosuppressive. Opioids are reduces the natural killer cells and impaired neutrophil chemotaxis. It also, there's a prolactin receptor on the T and B lymphocytes, which stimulates immune cell proliferation. So it actually inhibits the immune system by the mechanisms that which it goes around your body and scavenges for foreign invaders, bacteria or virus, by inhibiting lymphocytes. So being a clinician, this all is nice basic sciences information, but what does that relate to as far as society and healthcare as a whole? So there's actually 4 studies that looked at the infection risk and opioid use. They found 38% increased risk of community-acquired pneumonia for those that are in chronic opioid use. The Tennessee Medicaid data, when they looked at a state level, found that they had a higher risk of invasive strep. And there was a correlation with those patients that were on higher potency, longer acting and total higher doses had a higher immunosuppressive effect. So what if, number 3, what if we are actually causing harm to patients by using opioids? What if the negative side effects and the costs of the opioid to society don't actually outweigh the benefit? Something to ponder. So moving on to number 3. So what is pain? So doing anesthesia, I've had the opportunity to do a couple anesthesia for a couple organ harvests for donor patients. And during this time, they still need anesthesia because often the surgeons get in there and get aggressive and start tugging on stuff. And they still have tachycardia and hypertension as a response to surgical stimulation, even though they're brain dead. So that makes one wonder. And so if they're brain dead, how come they're still having these responses? And that's as they're reflexive. So what we're actually seeing is an autonomic response to surgical stimulation, but it's wrong to think of it as pain. So what I'm trying to do when I give this lecture to anesthesia providers, and for you guys too, is to kind of reframe this concept in your head that if you're using other drugs that have analgesic effects to modulate the sympathetic nervous system and mediate how neurologic signaling is transmitted from the periphery, that if you think about using other drugs other than opioids, that this opens the door, specifically during surgery even, that when they are under anesthesia and totally unaware, that if you use autonomic manipulative drugs to treat these responses instead of an opiate, that you might end up being better on the other end. So the reason I have the definition up here is that by definition currently, which isn't the best definition in my opinion, but it implicitly implies that the pain is an unpleasant sensory experience and emotional experience that is associated with actual or potential tissue damage. So that means you actually have to be conscious to process it to experience pain. Everything we're seeing when patients are under anesthesia is instead, by definition, a physiologic reflex of the sympathetic nervous system. So, and then looking at surgery patients overall, over half of all surgery patients still report moderate to severe pain after surgery, despite standard treatment being opioid-based analgesic therapy. So from that, we jump off and move forward with knowing that certain procedures also have a higher risk of chronic pain, such as amputation, mastectomy, thoracotomy. What about some of the other more common surgeries? So this is actually out of an article in 2019 that's looking at the incidence of chronic post-surgical pain after some fairly common ones. So we all know thoracotomy, mastectomy. You can see on the column on the left there that those incidences are noted, but some things that we do every day that you don't really think about: cesarean delivery. In some studies, up to 1 out of 2 patients have chronic post-surgical pain. Craniotomies, a third of patients. Hip arthroplasties, 1 in 4. Knee arthroplasties, up to 44%, almost 1 in 2, have some form of chronic post-surgical pain. Vasectomy, 37%. Just seems, these are things that procedures we don't typically associate mentally as providers with having chronic post-surgical pain, even though looking at the incidences of that, it is a real thing. So, and then the other thing they don't talk about is debilitating post-surgical pain. If you look in the second column, that's greater than 5 out of 10, up to 10% with cesarean, up to 25% with craniotomy, 15% with knee arthroplasty. It can just do a lot better, I think, if we especially start looking at these kind of outcomes. So this study looked at PACU admissions, found that roughly 10% had post-op nausea and vomiting, 7% had airway complications, and almost 6% had cardiac complications. Now, this is all cause. It's not cardiac arrest or MI. It's also arrhythmia and hypotension lumped into there. So, and then 2002, there's an Australian PACU study that showed 44% of respiratory complications. And so between these and several other studies, respiratory ends up being the most frequent cause of unexpected post-op admissions. And then the American Society of Anesthesiologists has what they call the closed claims database, and this looks at any lawsuit that was filed against an anesthesiologist. They keep a database of that so they can look at and do critical analysis of some of those complications. So from the 4 years that another study looked at it, they showed 37% of the claims involved a patient's death, and of those, 33% were respiratory events and 12% were actually airway injuries, which is interesting that they separated those out to me, but thus they did. So moving on, this article looked at opioid exposure as actually a risk for non-union and fracture reduction. Looked at claims data. So they looked at insurance info that was submitted for payment. There's a big, huge databases you can pull a lot of this data from for research purposes. And so they looked at 90 million patients. They found 300,000 fractures and controlled for previously identified non-union risk factors. Some of those non-union risk factors were smoking, high BMI, alcohol abuse, and a smattering of other comorbid diseases. So then of those 300,000 fractures, they separated opioid use into acute versus chronic, and then Schedule 2 versus Schedule 3 through 5. They found that the chronic opioid use doubled the risk of non-union. And if you remember back to the endocrine effects, the chronic opioid use is associated with bone demineralization and poor effects from there. Schedule 2 opioids showed a greater non-union risk than non-opioid analgesics. And the highest odds ratio for a non-union fracture was with the use of Schedule II opioids. Significantly, some of the orthopods I've worked with before do not like Toradol because it quote unquote inhibits bone healing. And this study actually looked at that and showed that NSAID use exposure is not significant in the risk of non-union. It's actually opioids that cause problems with that. So if you're interested in that study, that's in the Journal of Injury 2018. Moving on, this is one of my favorite studies just because it is so significant in the numbers that it puts forth. So Brummett in 2017 looked at new persistent opioid use after major surgical procedures in the US, and major being highest volume. So they again looked at the administrative claims data for 1 year, and they separated those into minor versus major surgeries. So the minor surgeries were varicose veins, lap choles, lap appies, hemorrhoidectomies, carpal tunnels, TURPs, those kinds of surgeries. Major surgeries, ventral hernia repair, colectomies, reflux surgery, bariatric hysterectomy. So a little bit of overlap there between kind of minor and intermediate, but they broke them down into 2 categories for the research purposes. So then, out of this administrative claims data, they looked at opioid naive patients that had surgery and then compared them to a group of opioid naive patients in a non-operative group. And so what they're looking at is for new persistent opioid use. So they gave these patients to look and to see if they'd filled opioid prescriptions as part of their healthcare claims for the previous year, and define them then as opioid naive. They also assumed that any opioid prescription less than 30 days prior to surgery is most likely assumed to be related to the surgery. So there's subdata, subgroups based in the results based out of that. And then comparing them to patients who didn't have surgery, the opioid naive patients in the non-operative group, they gave those patients a computer-generated surgery date and then looked from that random date to see if they had a new claim for in their insurance stuff for chronic opioid prescriptions. So before they started looking, they gave all patients in both groups a 3-month recovery period in which they could, recover from surgery and heal and try and wean off of narcotics. So exquisitely difficult study to put together all the data, especially with the numbers, but in my opinion, very well done and defined and controlled for. So they found that as a result, major surgery of those ones we listed before, 6.5% of patients had opioid use after 3 months following surgery. The mind-blowing thing for me is patients having minor surgery was almost the same. 5.9% of patients having minor surgeries were still using opioids 3 months after surgery. And then remember, the minor surgeries were lap choles, carpal tunnels, TURPs, appies, very common things that we do every hospital every single day in North America. Roughly 6% of those patients were still using narcotics 3 months following surgery. So compare that to the non-operative group. With the numbers that they used, with the volume of patients they used in claims data, they looked and found basically your baseline risk of a new opioid prescription not related to surgery during that time period of the study was roughly 0.4%. So factor 0.4 out of those numbers above, and the risk of persistent opioid use following surgery becomes roughly 6%. They also found that if you had a preoperative opioid prior to surgery in that 30 days, that your risk of new persistent opioid use following surgery was 2-fold greater, and that's even after adjusting for other factors. So they were able to conclude from this study that prolonged opioid use can be determined to be the most common surgical complication for all surgical patients, which is mind-boggling that we hadn't looked at this in this way before. So all of this data from this study is actually a repeat from a Canadian study, and the results previously are very, very consistent. So in my practice in a critical access hospital here in Wisconsin, we do about 20 cases a week. So using standard opioid-based analgesic techniques, that would equate to roughly one patient per week that I take care of would fall into these statistics as being a new chronic opioid user. Extrapolate that out to a year, 52 new patients that I take care of each year. Extrapolate that to, we do about 100 million surgeries a year. So by these numbers, roughly 5 to 6 million new persistent opioid users as a result of having surgery are created each and every year. Just mind-boggling to wrap your head around those numbers to me. So what if number 4? What if opioids aren't actually effective at treating pain? We said before that 50% of all patients still experience moderate to severe pain post-surgically. And if you look at some surgical subset populations, that number is as high as 76%. Unfortunately, in society, opioids have been deemed as quote unquote painkillers. And when you go to look for actually finding research that, looks at their effectiveness in treating pain, they're not out there. So despite the fact that we've got, that there's, we think that there's long-term benefit from that with respect to pain relief, that hasn't actually been documented by multiple studies. So a couple more, looking at anesthesia. In 1999, this is the Canadian Journal of Anesthesiology. They looked at patients. It was randomized and double-blinded. They looked at open abdominal hysterectomy. They had two groups, a low-dose group and a high-dose group. The low-dose group had 1 mic per kilo of fentanyl on induction. The second group, the high-dose group, absolutely marinated these patients in fentanyl. They got 15 mics per kilo on induction and 100 mic per hour infusion for open abdominal hysterectomy. Just massive, massive doses of fentanyl. So what do you think they found between those two groups, looking at low dose versus high dose? They actually found that the high dose group at every single time point had higher pain scores and consumed more opiate in the first day after surgery. Postoperative pain control in both groups were fentanyl PCA, 15 mics, Q5 minutes with a 300 mic lockout after 4 hours. And then they looked at time intervals 4, 8, 12, and 16 hours post-op. The group that got 10 times the amount of intraoperative fentanyl had higher pain scores and required more postoperative narcotics following surgery at every time point. So generally in healthcare, we think of opioid-induced hyperalgesia as a very long-term phenomenon, but I think it's very poorly understood and vastly underestimated. So this one was in the British Journal of Anesthesia in 2014. They did a meta-analysis and used those meta-analysis to control for low-dose opioid or placebo, and compared that to the experimental groups with remifentanil, sufentanil, and the traditional fentanyl. There are 17 trials that looked at pain at 24 hours, 11 trials looked at pain at 4 hours, 12 trials looked at pain at 12 hours, and at all time points in all of these groups, the experimental groups that got narcotics in traditional dosing fashion had a statistically significant higher pain scores. They had a higher PACU morphine consumption versus control, and their pain thresholds were significantly lower in the control group versus, the pain thresholds were significantly lower in the experimental versus the control group. So a pain threshold in a physiology lab is you cause somebody, you apply a certain degree of discomfort or pain-inducing stimulus, and their threshold at which they say enough is actually lowered in the groups that got remifentanil, sufentanil, or fentanyl. So the preliminary data on this suggests that opioid-induced hyperalgesia may contribute to the development of chronic post-surgical pain, and is seen just, immediately post-op when using these narcotics in traditional fashions. They also saw acute hyperalgesia in the remifentanil subgroup, as well as a trend towards hyperalgesia with the sufentanil or fentanyl, but it was underpowered. The hyperalgesic effects are less dramatic compared to remifentanil, but there was enough of a trend there that it was trending that way, but it was insufficiently powered to draw conclusions on those two drugs. So another study looked at esmolol infusion in the absence of opioids. Actually has a postoperative, spares fentanyl in the postoperative phase for lap chole. So this is in anesthesia and analgesia in 2007. They had patients having a lap chole. The control group was standard treatment with fentanyl, and then 2 experimental arms, a remifentanil infusion or an esmolol infusion. And this they did with, I believe, 2 anesthesiologists and 3 surgeons up in Canada. And so the control group had 1 mic per kilo of fentanyl on induction and 50 micrograms every 30 minutes. The remifentanil group had a 1 mic per kilo bolus, and then an infusion at 0.1 to 0.5 mics per kilo per minute titrated. And then the esmolol group had 1 milligram per kilo at induction, and then an infusion at 5 to 15 mics per kilo per minute during the case. So all the other aspects of the intraoperative care were standardized: Versed, induction drugs, paralytics, fluids, volatile agents, other multimodals that were given during the time, all standardized across all participants or patients in the study. And so they looked at what happened. Oh yeah, 2 surgeons, sorry, I got it backwards. 2 surgeons, 3 anesthesiologists that were a well-defined protocol. And the only thing that was variable was what narcotic or lack of narcotic they got. So what did they find? The esmolol group needed an average of less than 100 mics in PACU. The fentanyl group needed almost 200 mics of fentanyl in PACU, and remifentanil needed almost 250 mics of fentanyl in PACU as an analgesic. So comparing those numbers significantly, the esmolol group used less fentanyl, 2.5 times less than the remifentanil. And remember, the esmolol group got no intraoperative narcotics. Of note, the esmolol group also used less post-op nausea and vomiting treatments, but even though there's 7, you remember they were, sorry, I got ahead of myself. Even though they required some nausea vomiting treatment, remember that the patients who got none intraoperatively were still getting fentanyl in the recovery room. And then also patients, hospital systems like to look at time to discharge. The esmolol group had the shortest PACU stay compared to the other 2 opioid-based groups in this study. So the quote that came out of from the authors of the study is, "The result of the study indicates the intraoperative continuous infusion of esmolol with no supplemental opioids contributes to a significant fentanyl-sparing effect during the immediate postoperative period." So when I look at this and read this and digested this data, I don't conclude that it's a fentanyl-sparing effect. My conclusion is that the lack of opioids is not causing opioid-induced hyperalgesia, even during the relatively short lap chole surgeries. So jury's still out on that. I think the way this authors defined the methodology kept them from looking at and calling it a lack of opioid-induced hyperalgesia rather than a fentanyl-sparing effect. So we got a few more slides left. So this is another study by Barr in 2013. This is in the American College of Critical Care Medicine. This is their guidelines on opioid use in the ICU. Their normal standard treatment with fentanyl infusions in ICU is a dose range of 0.7 to 10 mics per kilo per hour. So let's just do some quick math. if you have a patient on 10 mics per kilo per hour and they're 100 kilograms, that comes out to 1,000 mics of fentanyl per hour, or 24,000 micrograms per day. If you use an opioid conversion calculator, so if you're wanting to wean somebody off of a fentanyl drip and give them oral opioids at the same equal analgesic dose, you dose reduce by 25%. So say you're going to move them over to oxycodone from a 2,400 mic per day fentanyl infusion. That equates to 187.5 milligrams per hour of oxycodone, or for a 24-hour period, 4,500 milligrams of oxycodone per day. What does that equate to in actually having to take pills? That is 900 5-milligram oxycodone pills per day. And the American College of Critical Care Medicine defines this as an upper end of normal dose ranging. Just mind-boggling. So, what if, number 5, what if opioid-induced hyperalgesia actually starts in the OR? And what if the high degree of chronic post-operative pain that we see actually we are causing? You think about cardiac surgery, those patients are marinated in fentanyl as well. They always are the hardest control on their pain. What if we are actually causing the hyperalgesia as opposed to actually treating it and doing what's best for these patients? The thing that's going to be researched in the next decades to come is they're actually seeing what percent of our surgical population are actually genetically predisposed to chronic pain syndromes as well, and or opioid abuse, genetically predisposed to opioid dependence. Something to consider. So, looking at the social impact, in short, the opioid epidemic is already the deadliest drug epidemic in American history. More people die from that each year than all other illegal drugs combined. And it is now, with the opioid epidemic, now one of the leading causes of death in North America. From in 28-year period there, opioid-related deaths increased 5x on average. When this I put this together, that was 115 people per day die from an opioid overdose. So, kind of put that into relatable terms. The opioid-related deaths that we've seen have actually been 3 times the number of Americans we lost during the Vietnam War. So in this study, which was 12 years, they saw 3 times the number of patients lost from opioids than we did in Vietnam. The only problem with Vietnam, it lasted just shy of 20 years. So it's an even faster rate than we're losing people in Vietnam. 15-year study here with Gomes showed an increased opioid-related deaths 345%. And then down here on this years of life lost, that's a public health variable that I wasn't familiar with, so I had to do some looking. So the years of life lost is how long is somebody expected to live, and then you subtract off the age at which they died. So someone's expected to live to 85 and they die of an opioid dose in their 20s, they lose roughly 60 years of life lost. So they looked at opioids and compared it to other conditions. The years of life lost from opioid exceeded hypertension, HIV, and pneumonia combined, and it equated for years of life lost was the same number as 1/10 of all cancers combined, which is just a staggering statistic from a society standpoint. So this is an important point before I get into this next one, is to point out correlation does not mean causation. And that'll be evident here in the next couple bullet points. So in 2019, the US population was 329 million. The world population was 7.7 billion. So the US population equated for roughly 4.25% of the world population. Of that, in 2017, the US consumes 80% of all opioid production in the world. So 4.27% of the world's population is consuming 80% of all the opioids worldwide. Again, there's a big, huge disconnect there. Medical costs associated with the opioid epidemic were at $72.5 billion in 2013. And then in 2018, one of these other studies looked at working age men who are unemployed. This is where correlation does not mean causation, just as a disclaimer, that of those that were unemployed, roughly half were taking a daily opioid. Now, if you go back to Dr. Portnoy's study, back in the beginning of this lecture, he found that there was no societal or personal gains in the social realm from chronic long-term therapy. And this study, I would argue, supports that. So looking also in emergency rooms, unintentional overdose in children, 6-year study, 22,000 patients, found a kind of bimodal distribution. The younger patients that were having an opioid overdose were unintentional. The older, high school age, were mostly intentional overdoses. In those 22,000, luckily there was only 11 deaths and only 39 required mechanical ventilation. But the cost of treating this is roughly 81 million just in emergency room charges. They found that the increase, this other study showed in 2016, I believe, showed that the increased incidence of 205% and a 300% in the subgroup 15 to 19-year-olds in accidental deaths. So how are patients getting opioids? Well, there's a new recreational consumption. We're looking at 4.3 million using opioids for non-medical reasons. The highest prevalence is in the 18 to 24-year-old population. 2,500 children per day of junior high and high school age misuse an opioid for the first time. 2,500 children in the US per day use an opioid for the first time recreationally. Half of them get it as their own prescription. 90% of them, once they start using it, get them from friends for free. 44% buy it, steal them from relatives, and then another 4 out of 5 purchase them illicitly. So, breaking that down societally, roughly 6% of all teens have used prescription opioids recreationally in the prior year. Ages 13 to 19, 6% have used recreational opioids. Just a dangerous path to be walking. So how are they getting them? Well, there's now things called pill parties where younger individuals come together, they empty a medicine bottle into a bowl and then grab a certain number of pills, unknown what they are, they're just in a bowl together and pop them in and see what happens. Also, another common method of obtaining prescription opioids is actually going into real estate showings. Someone occupies the real estate agent while somebody else looks like they're looking around and ends up going and raiding the medicine cabinets at real estate showings. Just something, I'm not that creative, but man, it's you can see how easy it would be to score a bottle of pills in that scenario. So if you're worried that you're not getting the best price for your prescription or your street drug, there's actually a website now called streetrx.com that you can see if you're getting a good deal on the street. So I'm just up outside Madison, and I went to look when I put this together. You can actually see that there's reporting just for our area that oxycodone and narcotics are overpriced. Vyvanase doesn't seem to be something too common around here, but Suboxone is actually a fairly reasonable purchase. So that's the downside. There's actually, this is all cloud-based data that people are self-reporting to just to kind of compare numbers and see what they're getting on the streets. And it's mind-boggling that they have such a beautiful, elegant, cloud-based resource guide for illicit drug use. So looking at it on the positive side of things, this is a fantastic resource up in Michigan with the OPEN network, and OPEN stands for Opioid Prescribing Engagement Network. And their mission is to prevent chronic opioid use and abuse. They have a ton of evidence-based practice recommendations for providers, patient education, as well as community. Their main thrust is reducing the community surplus of opioid availability. So there's actually guides for providers to say, you know, you did this type of surgery, or you were inpatient for this type of condition, medical condition. this is how much would be an appropriate amount to send them home with. So, looking at the swing of the pendulum, CDC in 2016, now that we're dealing with the opioid epidemic, the regulators are swinging the other direction away from, instead of supporting it, to trying to squash it. So 2016, they outlined non-opioid therapies for chronic pain. AMA dropped pain as the fifth vital sign in 2016. So if your hospitals are still making that part of the vital signs, that is no longer a requirement. DHS introduced the PrOP Act, which is Promoting Responsible Opioid Prescribing Act, and it removed prescribing pressures from providers, the ones that had previously been under the thumb of regulatory guidelines and licensure issues. So CMS has a forthcoming draft guideline that is going to require pharmacists to report providers that are over-prescribing, and that non-pharmacologic and non-opioid are going to be the preferred agents for chronic pain. So this will likely, now that there's a whole bunch of patients on chronic opioid therapy, cause an increase in referral interventional pain management and longer wait times, because these patients are going to be harder to monitor and incentivize to wean them from their therapies. So also, many states also have a prescription monitoring database that's going to require those individuals to check those before prescribing opioids in the future. So where are we going with this? ICD-10, it seems like we just survived the implementation, but now in May of 19, the World Health Organization already updated the new version of ICD-11. Little background on the ICD coding. It was adopted in 1990. The 10th version was adopted in 2016, and then 2019, they've updated to the 11th version now. So this update to ICD-11 actually created new sections for antimicrobial resistance, as well as new sections for chronic post-surgical pain and post-traumatic pain. So why did they do that? One, they're going to be able to study it better from a population level with more accurate coding. But then also, just like payers have done with catheter associated infections, ventilator acquired pneumonia, antibiotic administration prior to surgery, all those quality indicators. So now if you have a complication like a UTI or a pneumonia, well, they're not paying for the treatment of that separately. That's a complication of treatment, and the facilities will be are currently under the cost burden of treating that if it happens. So central line infections is another one too. So once they have the data on that, I strongly suspect that in 10 years, the development of chronic post-surgical pain is going to be reclassified with ICD-11 as a complication of surgery, and the treatment of this chronic post-surgical pain and the cost of it will then transfer from the payers to healthcare facilities. Now, so ICD-10 went from like 30,000 to 70,000 diagnoses. ICD-11 adds another 30,000 diagnosis codes to the previous version. So what if number 6? What if? So I started my career in healthcare in 1999 as an ER tech and as a EMT, and worked my way up to become a CRNA. I graduated in 2008, and for 10 years after, till 2018, I had a heavily opioid-based anesthesia analgesic practice. And in 2018, I began to research these opioid-free techniques in pharmacology, and the more and more I researched, the more I felt like Alice falling down the rabbit hole. There was just so much information out there that I had never been exposed to and heard before. And talking to other providers that are doing opioid-free anesthesia, it keeps me up at night to know that that there's a very real possibility that we are so far off track. So the thing that keeps me up at night is, what if everything we've been taught is wrong when it comes to opioids and treating patients? That's the one thing that really just haunts me. So With that, they say if when providers and healthcare looks at our generation of healthcare 100 years from now, what are they going to say about us, and what are they going to say we did to address this issue? So they say insanity is doing the same thing over and over again, but expecting different results. Each time a new opioid is introduced as the safer and newer alternative, it pans out in the end to not be true. So if we are not part of the solution to the problem, we are at risk for being accused of contributing and perpetuating the opioid epidemic. So with that, what are providers 100 years from now going to say? What did you do to fix this problem? So with that, a bunch of references and questions. Okay, in the chat, how does esmolol treat pain intraoperatively? Well, pain, with the International Society for the Study of Pain, that ICEP definition, pain is an emotional, sensory, alert concept. So intraoperatively, esmolol is not treating pain. What it's treating is the sympathetic response to surgical stimulation. So patients are unconscious if they're appropriately anesthetized, and you're not treating pain because the patients are not aware. That's where we were talking about if you can kind of reframe your paradigm on trying to wrap your head around that. When you're using it intraoperatively, it becomes much more of a palatable concept to think of. You're not treating pain, you're treating sympathetic stimulation with esmolol. So most of the time that's fairly short-lived, and even if you don't touch it with an opioid, the heart rate will come back down, blood pressure will come back down after a fairly short amount of surgical stimulation. So Elizabeth asked, why isn't it used more frequently if this is true? Are you talking about esmolol? Okay. Mostly because most anesthesia providers do not, from a philosophical concept, think that it is, and separate physiologic stimulation from pain. If you're looking at it from a purely definition standpoint, pain, like I said, you got to be aware for. All the anesthesia providers that I know that don't practice opioid-free anesthesia think of the intraoperative sympathetic stimulation as pain as well. They don't make a distinction there. So the reason it isn't typically used as frequently as it is that they don't frame it in their mind that way. And so that's not a treatment choice if it's not actually the root cause. The answer to that, I hope, is what you're looking for. It makes more sense in my head. I'm not doing the best job, honestly, to delineate that. But overall in anesthesia, the few of us that are doing opioid-free anesthesia, we are definitely the subset in anesthesia providers. And it's only when you think about it purposefully in that nature is the option for esmolol as a treatment for the sympathetic stimulation or surgical stimulation become an option. Otherwise, if you're treating pain, you give them a quote unquote pain medicine, and that goes forth and perpetuates itself in the OR. So any other questions on this lecture before we move on to the next one? All right, I'm going to switch to my next presentation. And if anybody, give you guys a chance to throw some questions in there if you got any more. While I get the other one booted up. How do you take care of the patient that is grimacing as they roll into the PACU bay? So um, my goal is that my patients aren't grimacing rolling into the PACU bay. Uh, so we get very aggressive doing opioid-free anesthesia using multimodal. So in pre-op, we use Tylenol, gabapentin, Celebrex orally. Our practice, we regional block everything that we can, so that definitely adds. And then intraoperatively, we use the esmolol. We also use magnesium, ketamine, Precedex, Ofirmev, if they didn't get oral Tylenol pre-op, as well as a host of other things to preemptively multimodally treat pain. And if you can spare the intraoperative opioid effects, there are some patients that end up needing some narcotic titration in recovery room, but that puts you guys as recovery nurses in the delicate situation as making the initial titrations to the post-operative analgesic regimen. Now, that being said, which we'll get to kind of in the weeds later in this lecture, is patients that have not received any intraoperative narcotic opioid analgesic are, since they haven't been exposed to it, there's no opioid-induced hyperalgesia that occurred during the surgery. The patients that have already preloaded with multimodal are much more receptive to much lower doses of narcotic in the recovery room as well. So when we get to the end of this lecture, Elizabeth, with your question on grimacing and rolling to the PACU bay, there's something that absolutely floored me at the end of this lecture regarding the use of narcotics in the recovery room. So with that, more to come. All right, any other questions before I move on to this one? Going once, going twice. Am I doing okay on time? Okay. All right, opioid-free anesthesia, implementation and outcomes. So this is, we're going to take a look at hurdles to implementation, process that I used for implementing, and then taking a deeper look at the data that came from my practice, and then look at a case study and where do we go from here. So again, no disclosures. So I'm currently in Wisconsin. I've been here 2.5 years, but before that, I was the CRNA at Grundy County Memorial Hospital in Grundy Center, Iowa. It's a 25-bed critical access hospital. It's part of the Unity Point system, which is one of the largest health systems in the country. I think they are I think they're pushing 40 hospitals now in the health system, and they each have regional hubs, and then there's smaller critical access hospitals that support each of the hubs. So I was at one of the critical access hospitals that supported the main hub, which was in Waterloo, Iowa. So I gave this lecture first in Maine, and most people on the coast look at flyover country and go, where the heck is Iowa? So it's in Idaho, Ohio, which is the great potato corn tire state. If you're more familiar with geography and more geographically inclined, Iowa's right here in flyover country in the middle of the Midwest. Specifically, Grundy Center is just outside Waterloo. Des Moines is the state capital, and it's about an hour and a half drive down to the capital from there. In Iowa, I was there at this hospital for 7 years as the sole CRNA. We did not do obstetrics, and so we were Monday through Friday without call, which was kind of nice. Other things in Iowa, down in south of Iowa City, is Maharishi University, which is the international home for transcendental meditation. Sliced bread was invented in Iowa. There's more hogs than humans. There's 21.2 million hogs versus 3 million people. If you guys remember the song American Pie, the day that music died was just west of Mason City there on the map. Buddy Holly, Richie Valens, and the Big Bopper died in a plane crash in Iowa. Southwest of Des Moines, John Wayne was born in a town called Winterset. And then it's also home to the world's largest annual bike ride. And so for 8 days, they go from the west border of Iowa to the eastern border of Iowa every year, and there's roughly 40,000 bicyclists that make the roughly 600-mile bicycle ride over 8 days, and it is an insane sight to see how many bicyclists do this every year. So Iowa is also fairly unique. It has 25% wind energy, but also gets very hot there in the summer. This is an actual screenshot from the newscast in Cedar Rapids. January 30th, this was 2019 when I put this together. The wind chill factor was -55 Fahrenheit, and the heat index on July 20th, almost 6 months to the day later, was 111 degrees. That's 166 degree difference there. So for those of you less familiar with the Midwest, it's a little summary on Iowa. So looking more at the hospital, I was the sole CRNA. We had 2 orthopods through a general surgeon, gastroenterologist, podiatry, ophthalmology, came for cataract surgery 1 day every 3 weeks. And then I also did interventional pain management in addition to OR anesthesia there. This is the top picture is our preoperative holding area. We did roughly 850 procedures a year. We had 1 operating room, 1 endo suite. I was the sole CRNA. Did about 65 total joints before I left. And then the pain practice was fairly limited. Did mostly lumbar interventional stuff for chronic pain in addition to the OR anesthesia. So the advantages I had with implementing an opioid-free anesthesia practice was I was the only one. I didn't have to sell it to any of my colleagues. And so once I got my head wrapped around it, I could just kind of start. The hospital was actually part of the Iowa Department of Public Health. They had an opioid initiative that was looking at addressing the opioid epidemic. So my work with this dovetailed nicely with that. And then since when I started doing this, I had already been there for 5 or 6 years. So I've had well-established relationships with the surgeons and the OR staff, which made convincing them a whole lot easier that this was the way to the direction to move. So once I felt prepared after wrapping my head around it, I was able to just kind of start. So hurdles. What's the #1 hurdle to anything? Surgeons. We feel it too. Luckily, our surgeons at this hospital were skilled and fairly well reasonably behaved. Again, had working relationships with them. And over the time while I was trying to wrap my head around the transition and understand opioid-free anesthesia, I was able to make an informal introduction to it with the surgeons. They needed lots of reassurances, as they most often do, that this transition wouldn't hold up their OR schedule and clinic schedule. And then one of our surgeons in particular liked to talk about difficult cases and how they were handled and whatnot. And so I used that opportunity as I was wrapping my head around it to discuss those patients and how making the transition could probably actually have helped in those different scenarios. The OR staff, I definitely wanted to expose them early to the idea to making the transition. I made a point to kind of start with why, and instead of trying to get into the weeds of the physiology and the pharmacology, look at why this is a problem, way we're doing it currently, and why we should transition. So with that, I made a fairly formal presentation. There's actually a really good friend of mine who's got a phenomenally well distilled lecture that he gives called Abandoning the Mu Receptor, that looks over the pharmacology and physiology, and was able to give that to them as kind of some background education on opioid-free anesthesia. And then obviously, since I was the only CRNA there, I was readily available for questions to them. And then it dovetailed nicely with the public health initiative from the state. So luckily, I had awesome PACU nurses to work with who were willing to come in early to get some blocks done before surgery. And we're also willing to shuffle the OR schedule around. Since we had just the 1 OR, it was up to us to figure out how to set the schedule to most optimally facilitate timing and turnover and whatnot with the requirements for each surgery and patient. Other hurdles, pharmacy. I had to get Precedex on formulary. We already obviously had mag sulfate available with ER and ACLS, but had to get it stocked in the OR. And at the time, our pharmacist also got a hood, so she was able to split the vials of ketamine from 500 milligram bottles. She split them out into pre-filled syringes for me under the hood, and then I had 50 milligram syringes pre-filled that I could use for the patients and be much more judicious with the ketamine usage. So the formulary request took some time, access to the medications, and lots of reassurance to pharmacies. Most of the time, since we were a critical access hospital and the surgeons I worked with were pretty skilled, our cases were pretty short. So for bigger institutions with much longer cases, especially with surgical residents, using opioid-free anesthesia results in concocting a opioid-free infusion called the McLot mix, which is a friend of mine that came up with this concoction, and it's a set ratio of magnesium, lidocaine, ketamine, and Precedex that runs during long cases as a continuous infusion of analgesic, opioid-free analgesic, as a part of the surgical anesthesia. Also, we needed some equipment. We budgeted for a new ultrasound, and we had an existing syringe pump that had to get reconfigured to add in options for lidocaine and Precedex infusions as part of this. So perhaps the biggest hurdle was educating myself about opioid-free. It's a very intimidating process, especially after I've been practicing for 13 years, to throw everything I knew about anesthesia kind of out the window and start from scratch with the new direction. So I knew there was a lot I didn't know, and like Alice falling down the rabbit hole, the further I went, the more I realized there was to know about opioid-free anesthesia and how to help facilitate the transition. So being in a small town hospital, the town was only about 3,000 people. People like to talk in rural Iowa, and so the thing I was really worried about was complications from the transition. And so I wanted to do my best to weed out the danger areas and how to set some boundaries for myself with being able to do this safely and effectively, and minimizing any complications in the learning process. So did a lot of reading. I probably read articles and spent the initial 9 months or so wrapping my head around this and trying to figure out just where I could get all the information I needed to understand. So kind of as a side tangent, there's this website called Sci-Hub, which is put together by this gal. Her name is Alexandra Elkaban. She's at the time, she was a 24-year-old software engineer in Kazakhstan. And she was really frustrated that in Kazakhstan, she couldn't get access to any journal articles she needed for her master's. So she basically put this website together called Sci-Hub. If you guys are not associated with university settings or university medical centers, this is actually a way to get access to some of those articles that you're looking for if you're looking to research anything. So Sci-Hub is basically the Napster of academia. It bypassed the paywalls of the academic medical publishers and other specialties as well, but basically of all academic papers. It returns roughly 99% of all article requests, and this Alexandra Elkaban has actually been sued by the American Chemical Society and the American Journal publishers because she's created a backdoor to those articles. So she's currently hiding in Kazakhstan to avoid extradition to the US, but Elsevier is by far the largest publisher, at least in medical journals. Don't feel too sorry for them if they're losing out, because I did not know this until I started researching it. Elsevier actually, in addition to medical publishing, is also an international arms dealer. So they've sued her as well, but it's hard to make a case that they're truly at harm from a result of her action. So anyway, Other hurdles I had to address was networking, working as a sole CRNA in the hospital. Um, I didn't have any colleagues I could really pick their brain off of. So I joined the Society for Opioid-Free Anesthesia, went to state meetings, and, you know, I tried to find everything tool I could to kind of wrap my head around this. So I actually went looking for the Idiot's Guide to Opioid-Free Anesthesia, and turns out it doesn't exist. So as a result of reading for these 9 months and trying to wrap my head around it, um, I came up with the idea that I needed to go slightly different direction. So in general, this process was over a year after I'd wrapped my head around it and to make this transition. So the data that's going to come on the remaining slides was gathered between August of 17 and April of 2018. And so we looked at January before, as I was reading, I took August to April to do my reading and try and wrap my head around it. And then as I was finishing wrapping my head around it, we started I went back and collected data on control. So I used January and February as the control. That was where I was still doing opioid-based anesthesia as usual. And that allowed me time to kind of implement and address some of those hurdles too. Educated myself on the OFA, served as a control data, and I was just really having a difficulty keeping everything straight, trying to wrap my head around it. So I created a rough draft of the opioid-free anesthesia guide, which is this synopsis that I put together. And I actually broke it down into 4 phases of care: pre-op, intra-op, PACU, and post-procedurally, either inpatient or outpatient. And then also delineated between minor, intermediate, and major surgeries, and then the pharmacologic selections and dosing available in each. So I'm a very checklist oriented minded kind of guy. And this was the best way I could come up with to try and keep it all straight. So this is actually something that's available on the membership side of the Society for Opioid-Free Anesthesia's membership website. So moving on with the process overview, we took 4 months for the implementation phase, and then used data from 2 of those 4 months as the control, where we were doing the so January, February is the control. The implementation phase, where we actually started doing opioid-free anesthesia, was May and June, and during that time started using ketamine, Presidex, magnesium as part of the perioperative pharmacologic cocktails. And then September and October we used as post-implementation data once we were kind of fully up to speed and made the transition, to see just where we had come with that. That 2-month phase in September, October of 18, we also got our new ultrasound as opposed to our old ultrasound. So we were able to offer a few more regional blocks with that, but I don't think it's significantly contributed to the transition, because we were doing blocks before the core majority of our blocks we were doing with the old ultrasound were still done in the post-implementation phase. So looking at pre-implementation, so before we actually made the transition, I looked at our electronic health record. Did not have intraoperative functionality. The health system hadn't upgraded to intraoperative anesthesia records yet. So we did our pre and post-op notes in Epic, but we were still intraoperatively paper charting. So getting a hold of all those records was kind of hard. So instead I got the pharmacist to run reports for the OR to use as a surrogate for opioid administration. So whenever opioids were checked out of the Pyxis, it was assumed that they were used and administered. Again, no intraoperative anesthesia record to query, and being a critical access hospital, we also didn't have an informaticist to help build reports on pain scores or any of that stuff. The endoscopy part of our practice, my practice, was already opioid free. So colons, EGDs, sigmoids already were being done opioid free. So that also contributed to some of the minimizing the impact of the outcomes data. And then the surgeons didn't really change their prescribing practices for pre and post-op, as well as post-discharge opioids. We were just looking at the in-hospital perioperative phase. And then again, our practice, we use regional anesthesia as frequently as possible. Most of the blocks we did at this practice were interscalenes, adductor canals for total knees, pop sciatics for lower extremity ankle stuff with podiatry. And that accounted for 95% or more of the blocks that I was doing during this project. So the nice thing is our surgeon, once he was doing total knees at least, also put an injection through the surgical field into the posterior capsule of the knee, which helped cover the posterior pain quite a bit. But that's something that was done through all phases of this as well. So just as a disclaimer that might contribute to it. So how many patients did we have? So in each phase, pre-implementation, implementation, and post-implementation, we had those numbers for patients. Those were all patients that were coming for surgery, which resulted in a total of 352. So if you look at the numbers, why was there so fewer patients in the post-implementation phase? Well, that's because it's Iowa, and during September and October, there's a lot of corn. As much corn as we harvest, we only have about 3 weeks to do it in the fall. And so patients and whole families and towns reorganize themselves to help support the harvest. And in Iowa, there's corn and beans just about everywhere. So roughly there's 3 weeks during that time that you have to basically mow the entire state from the agriculture crops. So looking at pre-surgical and post-surgical surgeon dispenses, this is how many preoperative oral narcotics were dispensed during the time. So you can see the surgeons were fairly consistent. And then we looked at intraoperative dispenses, what was anesthesia given during each of the implementation phases. And you can see a steady drop there on the opioid use. And total dispenses between anesthesia and surgeons went down significantly as well. So we're going to dig into this a little bit deeper here in the coming slides too. So looking at anesthesia meds, what were we giving before we made the transition? So what's our control? We had fentanyl, Dilaudid, sufentanil, Demerol, morphine. And you can see that by far, as you would expect, fentanyl was the most commonly used drug during that time. So looking at the surgeon, oops, I might have went one too far. Looking at the surgeon's meds, they were obviously no oral meds were given in the OR, and very few during, or actually none during the preoperative, postoperative phase. And then obviously the surgeons were ordering the oral meds, oral narcotics in their perioperative phase. So looking at a summary of that, in the pre-implementation phase, we gave a total of 72 narcotic doses in the OR, 23 doses in the pre and post phase were given, and then the surgeon ordered an additional 7. So implementation highlights. Case mix, our surgeons were quick. Our one surgeon would actually do a total knee in under 40 minutes, skin to skin, which was just crazy. But he's one of those guys that once you get him laid down and prepped, you bring your hands back because you're likely to lose a finger if your hands are on the field. So we had total knees, total hips, lap choles, quite common. We were not, and we continued the regional anesthesia use from the pre-implementation phase. So the implementation phase, this is moving into the phase where we start adding in opioid-free strategies and techniques. So again, our cases weren't ever that long, so I never set up like a lidocaine infusion to use intraoperatively. I just instead would rebolus 1 milligram per kilogram about every 30 minutes. So let's see, what else? We began using pre-op gabapentin, Tylenol, Celebrex. Patients with sulfa allergies technically are not supposed to have Celebrex. So in that case, we use meloxicam as an alternative. But the sulfur allergy with Celebrex found out that's not really that big a deal. It doesn't cause anaphylaxis or anything like that. It's just some people are a little more sensitive to it with other more minor side effects. So now at our current practice, we give Celebrex to pretty much everybody we can. So began using low dose ketamine during the implementation phase, 0.5 milligram per kilo, ideal body weight. Precedex, 0.5 mic per kilo, ideal body weight. And then lidocaine induction bolus. I had always been given a milligram per kilogram, but during this time I upped it to 1.5 milligrams per kilogram as part of the induction bolus to bump up that plasma level with lidocaine. Also began using magnesium. The dose range on that is 30 to 50 milligrams per kilo over 20 minutes as a loading dose, and then a 10 milligram per kilo maintenance infusion. And again, our cases were short, so we didn't really do that. We didn't use any Esmolol at that time because I already had enough to wrap my head around with everything, all the changes we were making, and I didn't want to cloud the picture that much. Plus, at the time, I didn't really wrap my head around why Esmolol was used as part of the opioid-free anesthesia. So without having a good understanding of it myself, I skipped that part as part of the regimen. So one of the hurdles here is when we transition to the pre-op oral meds. It took some time to get the pre-op RNs to give the meds first thing as soon as the patient walks through the door. I just wanted to allow as large an NPO interval between arrival and induction as I could, as well as, once they're under anesthesia, the gut function tends to shut down a bit. And so I wanted to get as much of a absorption as I could between arrival and induction. So those meds could be on board and contributing to the intraoperative analgesic regimen. So looking at IV medications, we had a total of 62 IV or intrathecal opioid administrations during the implementation phase. So down from the pre-implementation phase for sure. The surgeon meds stayed fairly consistent, a total of 8 oral prescriptions administered in the perioperative phase during this time. And so looking at that overall, you can see the OR administration went down, pre and post administration went down, and the surgeon's administration stayed about the same. So headed in the right direction with making this our goal. Things I learned from the implementation phase: for cases that are short, less than 60 minutes, the 0.5 milligrams per kilo of ketamine and the 0.5 mics per kilo of Precedex seemed to be a little bit heavy-handed. My patients were a little bit sleepy in recovery. And so I reduced, especially for the shorter cases, down to like the 0.3 per kilo range for Precedex and ketamine. I also found that especially with the Precedex, the younger the patient was and the more healthy their sympathetic nervous system, they seemed to be more sensitive to the sedative effects of the Precedex that I was given. I also noticed that the lidocaine boluses seem to be more effective in soft tissue general surgery versus bony orthopedic surgery as far as its analgesic effect. And I think that's partly due to the underlying blood supply to the soft tissues is much better than the bones themselves that they're working on. So, therapeutic plasma levels of lidocaine seem to be more effective in the tissues with greater blood supply, if that's what you're working on comparatively across surgical specialties. Notably, at the 0.3 to 0.5 milligrams per kilo dose of ketamine, I did not observe any of the negative psychological side effects that are typically traditionally associated with ketamine at these doses. So would be a little bit more heavy-handed at the beginning of the cases with the loading these patients up and then letting it trickle off by the end. And by the time they were waking up, nobody was freaking out or having hallucinations or any of that stuff that's typically associated with ketamine. The other thing I found is mag sulfate will definitely potentiate the rocuronium. So there is consensus that it has the potential to increase the duration of action of rocuronium synergistically up to about 20-25%. So if you were expecting rocuronium to wear off in an hour, it might start to wear out, take 80 minutes or so to start to wear off. So just a little bit of adjustment there, and something we can definitely monitor with our Twitch monitors in the OR. So post-implementation data, looking at IV medications, we reduced that to a total of 14 dispenses and uses during the post-implementation phase, which was the final 2 months after we'd made the transition. Oral narcotic in the perioperative phase was again surgeon ordered and pretty consistent with the 6. And then looking at everything all together, you can see with each phase, we steadily decreased the amount of intraoperative opioids used, as well as the amount of pre and post-operative opioids used IV. And then the surgeon ordered continued pretty steadily during each of those phases. So in the post-implementation phase, I did use narcotics on 6 of those patients, and ironically, the 6 of those patients that I needed to give narcotics to intraoperatively were also the 6 patients during that time that were on chronic opioid therapy. So what I found is doing opioid-free anesthesia, especially for somebody that's chronically on them, is difficult. However, if you think about it in terms of somebody that's coming for surgery that's on chronic opioid therapy has developed a relative physiologic baseline need for exogenous opioids. And so the amount I gave was basically supplementing their baseline physiologic need, and the opioid free part was a relative opioid free for those patients that are chronically using it. So Laura had a question here that I just noticed in the corner of my eye. Do I notice any difference if you use Ofirmev versus PO Tylenol as part of the technique? The studies that pharmacy always likes to quote is there is no difference in outcomes. However, based on a higher plasma level of giving Ofirmev versus oral Tylenol, there's the area under the curve is same, but the pharmacokinetic graphs are markedly different. You get a much more immediate, much more higher plasma level of acetaminophen with the Ofirmev given IV. The other thing is surgeons will tell me subjectively that they see better pain relief with Ofirmev over oral Tylenol. But pharmacy still is beating their drum of there's no clinical difference. So I think there's going to be some more data coming out on that. The other nice thing is Ofirmev, as of this past December, has gone generic. So instead of it being $40 a bottle, it's still much more cheap. My practice in Iowa, we used oral Tylenol just as because we were already given Celebrex and gabapentin and all the other stuff. My current practice, just in our culture, is we skip it in pre-op and end up giving it IV during the case. So I think there's better relief from Ofirmev. However, is it cost effective, better relief? The jury's still out on that. So, okay. Yeah, I think I see better relief from Ofirmev, but we're still waiting on more data. So also Kathleen also sent me a direct message with a question, so you might not be able to see this. Do you believe the traditional negative side effects of ketamine are more a result of being administered in combination with opioids, or are the side effects mitigated by something else? So ketamine, if used as a sole induction drug, the dosing for that is anywhere from 3 to 5 milligrams per kilogram as a single bolus. That produces a fairly significant blood level of ketamine. And as patients are coming down from that, you see the hallucination side effects with the plasma level much higher than we do in the opioid free anesthesia dosing of like the 0.5 per kilo. Like when you see the side effects, with higher dosing than we end up using in the opioid free. So most of the ketamine side effects that we are avoided altogether based just on the dosing. And a lot of the hallucination, the psychotic side effects from that are traditionally described back in the 60s and 70s when it came into the market with much higher dosing than we're using for opioid free. The other thing is I tend to front load my cases preemptively a little bit more with the ketamine, and then let the plasma level kind of percolate by the end of the case. So a lot of the psychological side effects come with immediately after it's administered, and you get a rise in the plasma level. A lot of that's on its dwindling down as we're transitioning at the end of the case to the PACU. So does that answer your question, Kathleen? Okay, perfect. So yeah, when doing this, keeping the ketamine around the 0.5 milligrams per kilo is, I didn't have any patients complain of any, negative hallucinations or psychological side effects. All right, highlights from the post-implementation phase. We reduced from the 0.5 mics and milligrams per kilo of Precedex and ketamine down to the 0.3. That helped reduce the PACU drowsiness. Interestingly enough, when we had no intraoperative narcotic administration, our PONV rate went to 0. Nobody needed interventional treatment for 2 months in full-time practice. Now, if patients were coming in with a history of post-op nausea and vomiting, we were prophylaxing them with Pepcid, Zofran, and scopolamine, and we were already using propofol sedation for like our total knees, total hips, which is antiemetic in itself. So the combination of that with not administering opioids at all contributed to a 0% of patients with post-op nausea and vomiting. And then again with the blocks was a very small subset, but we started adding TAP, rectus sheath, supraclavicular, and IPAC blocks as part of the operative block regimen. So looking at total peri-op summary, 124 patients in the pre, 131 in the implementation phase, and then the low number 97 patients in the post-implementation phase. You can actually see that in the third column there, 82% were receiving no opioids in the implementation, reduced that to half in the implementation, and then the post-implementation phase, only 20% of patients were getting opioids. So from start to finish, that was an 80% reduction in opioid administration for our hospital in the perioperative phase. So breaking that down further, we looked at just the intraoperative administration and separated out the surgeon administered or surgeon ordered oral opioid medications. So in the pre-implementation, 60% roughly were getting opioids. Implementation, we reduced that by 40% roughly to 1 out of 3. And then in the post-implementation phase, we reduced that another significant percentage-wise down by another 86%. So only 6% of our surgical patients were getting in any sort of perioperative narcotic. So total reduction of the intraoperative dosing was actually almost 92% reduction of intraoperative dosing. During that post-implementation phase, only 6 patients out of 97 got intraoperative narcotics. And again, those are the ones that came in with chronic opioid therapy as part of their surgical or medical history. So how do we wrap this up into something kind of tangible that tells a nice story? I had a 68-year-old female coming to me for total hip arthroplasty. She just also happened to be one of our inpatients nurses' mothers, who took care of a lot of our ortho patients and joints. So she had a past medical history, hypertension, high cholesterol, and obesity. She's had an LAVH and 2 total knees, and now she's coming needing her hip done. So fairly common patient, I would say. All 3 prior surgeries, the LAVH and the total knees, required 3 to 4 days admission for intractable postoperative nausea and vomiting after surgery. She came into us using a walker because she had waited so long to have surgery and wanted to avoid and kept putting it off of having another round of this intractable nausea and vomiting. And her average daily pain score for the orthopedic notes was 7 out of 10 to the hip we were going to be working on. So she lived with severe hip pain on a daily basis and had been putting this off and putting this off. So what did we do for her? Preoperatively, we did our oral regimen, a gram of Tylenol, 200 Celebrex, 300 of gabapentin. She had the PONV history, so we prophylaxed her pretty heavily. Zofran, Pepcid, Reglan, scopolamine, and then also did the intraoperative propofol infusion after a spinal. We did a fascia iliaca block, which is a great block for hip surgery. However, it has the downside effect of postoperatively, they have a bit of quad weakness until the block resolves. So we did the block preoperatively with Versed, ketamine, and Precedex as sedation, and used dilute ropivacaine with Decadron to try and help spare as much motor as we can, but still provide the analgesic benefits of the block. So intraoperatively, did a straight spinal, no intrathecal narcotics with heavy marking for the total hip. We gave her occasional ketamine and Precedex boluses, propofol infusion for maintenance, and then also gave her mag sulfate bolus, 2 grams for her without the maintaining infusion. So the surgeon that did her hip also does his hips in under an hour. So other than the propofol, no continuous analgesic infusions. Postoperatively, she had mild to moderate quad weakness, and overnight that resolved by morning rounds the next day. So 24 hours later, she was up and walking the halls. She had 0 out of 10 pain with ambulation and not receiving a nanogram of narcotic leading up to that. She was discharged post-op day 1 for the first time without any nausea and vomiting, and she was taking Tylenol and ibuprofen for her analgesic regimen. Follow-up, since she was one of our nurses' mothers, I actually ran into her at the gas station about 2 months post-op. She had 0 opiates during her entire recovery from her total hip arthroplasty. This included during her physical therapy sessions. Sure, she said her maximum pain score post-operatively was a 2, even during PT. And again, first surgery ever without post-op nausea and vomiting. So what can I conclude from making this process transition? I didn't try to conclude anything. I didn't design it to draw any significant conclusions. It's not a big enough number with our type of practice or my type of practice at the time to draw any conclusions. We didn't set any proper controls or methodologies for that. So I just wanted to see what kind of a dent could I make by trying this transition and changing my practice, basically. It seemed like at the time a process that kind of took as much effort as it would to turn a cruise ship from the way it was tacking to changing the direction. And I was honestly skeptical that I could actually make this transition and make this work. So doing all of this data analysis I did after the post-implementation phase, and then kind of distilled through it and worked through it to see just what kind of effect it had. And to be honest, I was absolutely surprised that it had as a big effect and was as successful as it was. So the other things with the post-op nausea and vomiting, we eliminated it in the post-operative post-implementation phase. But however, we weren't at the time performing any high-risk post-op nausea and vomiting procedures. We weren't doing breast, we weren't doing GYN. And also the thing is I wish now I would have looked at, but didn't, was measuring time to discharge. So drowsiness is perhaps a bit more drowsy than the opioid free. But again, asking the nurses, PACU nurses subjectively, it did not seem to affect subjectively their time to discharge. So now that I've got these tools under my tool belt, when I moved to Wisconsin, the one thing that I took a little bit of education and insights to get my current PACU nurses on board is they were complaining that my patients weren't opening their eyes. They were too sleepy. And so if you've ever worked ICU, you know, one of the long-term or effects of Precedex is they appear to be sleeping, but when stimulated, they'll easily arouse. And so the same thing is happening now at my practice in Wisconsin with using the Precedex. Is they look like they're sleeping, you go over, tap them on the shoulder, and yeah, they wake right back up, and then they fall back to sleep. So it's a very tranquil state, but the nice thing is they're no longer narcotized. They sleep like they're naturally sleeping, which is kind of the effect of the Precedex, and not narcotized like they are with opioids and high CO2s. So the other thing that was really interesting to me was the surgeons, their opioid prescription stayed fairly constant, and I expected that the PACU opioid administration would actually increase by using an intraoperative opioid-free technique. So I was expecting that by the time we hit PACU, that there would be an increase there. However, surgeon was fairly significant. OR was obviously decreased. The thing that was interesting to me was by omitting opioids intraoperatively, we actually decreased the amount of opioids we used in the postoperative phase, which was absolutely mind-boggling to me. And again, now that I've dug further into it, I think this is the clinical effect of avoiding acute hyperalgesia from intraoperative opioid use. And then looking at the ratio, so even though the ratio changed, the total dispenses was down by 90% intraoperatively. So where do we go to next? We talked about ICD-11. I'm just going to leave that up there since we talked about that in the last lecture. But so as the sole CRNA at my hospital, this was just my first baby steps towards implementation. I now have a good friend and colleague who does opioid-free anesthesia. He does travel the full time. He's actually licensed now in, I think, 27 different states. He's now gone 5 consecutive years without giving a single intraoperative opioid to any patient. That includes the chronic opioid users. And he works everything from critical access to level 1 trauma academic centers when he's doing his travel and locums. So, what is possible with full perioperative implementation? You got to get the surgeon buy-in, and if you can get them to also amend then their postoperative discharge prescribing, that'll be huge. And that's what that in the last lecture that Michigan Open Network was aiming at. Getting hospitalist buy-in for those that are taking care of surgical patients postoperatively, and then scheduling NSAIDs and Tylenol and gabapentin postoperatively is unbelievably important. The floor nurses are already running their tails off, and when those non-opioid analgesics are ordered as PRN, they're typically not given. So getting the hospital as a system to schedule analgesics is going to allow for less frequent opioid administration in the inpatient recovery phase. So where do we go to next? Dr. Moulier, I said, talked about at that first opioid-free Congress. We want to understand just how underestimated is opioid-induced hyperalgesia. I think it is, from what I've seen clinically and read, researching this and talking to colleagues that do opioid-free anesthesia, it's the number one factor that is underappreciated and misunderstood when it comes to surgical anesthesia practice. Giving those opioids in the ER is, in my opinion, absolutely contributing to hyperalgesia, even as early as waking them up and being in the PACU. So we need to also better understand and quantify the anti-hyperalgesic and anti-inflammatory effects of OFA. So Tom, the guy who founded the society, even though he named it the Society for Opioid-Free Anesthesia, it's a bit of a misnomer. Even though it's a mouthful, the perhaps better description isn't necessarily that you're omitting opioids is the important part. It's but the analgesic regimen is aimed at being anti-hyperalgesic and anti-inflammatory in nature. So, and then also need to know what are the short and long-term negative hormonal effects of opioid-based analgesia. This is where Dr. Moulier started just a second ago. He presented his research from Belgium, and he has data that looked at cortisol response, which is, the general surrogate marker for stress response to surgery. And he showed that the cortisol response is roughly 1/3 of that during and post-operatively than it is compared to opioid-based anesthesia. So it's lower stress response using the multimodal opioid-free techniques than it is compared to traditional opioid-based. And then the other thing is MD Anderson is probably the premier cancer center in the country. They've actually abandoned opioids and volatile agents about 10 years ago in favor of regional blocks and opioid-free total IV anesthesia. And they're looking at cancer outcomes and actually showing, they have early data showing improved long-term outcomes by changing the intraoperative regimen to opioid-free with regional and avoiding the volatile agents, which also have immunosuppressive effects, and avoiding opioids altogether. So that's something they're looking at right now and have been doing for the past decade at MD Anderson. So where do you want to go for more data? Start with extensive studying. If you're going to make a transition, this is, again, you're going to feel like Alice falling down the rabbit hole. SOFA memberships are something that's an option. And then these are the two articles that I have all of our nurse anesthesia residents read. These are fantastic articles that go over the very basic science of physiology and pharmacology when it comes to opioid-free anesthesia. So if you guys are looking for something to read up on, I can actually email the National Library of Medicine link to these to you guys if you're interested in them. I'll email that to Diane and Laura to distribute to you guys. So more tips for implementation: network with other people that are doing it, preemptively address the hurdles to implementation. And then I took advantage of talking with the surgeons about opioid-free again, and I started very, very slow and purposeful. I didn't want to get into trouble, but definitely wanted to avoid some of the pitfalls there and make sure I was doing it right from the get-go. And then this is not an overnight change for me. I've been doing anesthesia for 13 years before I made the transition. So throwing out everything I'd learned before, as I didn't learn to do anesthesia overnight, and I certainly didn't learn to do opioid-free anesthesia overnight, but with some patience and persistence and purposeful direction, I definitely was able to make it there. So our front page to our website, this is screenshots a couple years old. We already had the Congress in 2019, but that's our website for the society. If you're interested, you can check out some more stuff there. We got a bunch of, on the membership side, have a bunch of protocols, a bunch of research, tutorials, field guides, membership discussion forums, and a whole lot more. And we're actually expanding. Our nurse anesthesia residents are contributing their opioid-free DNP projects to be shared on there as well. So a lot of good information coming, and it's a work in progress. We got a whole bunch of backlog stuff to get uploaded. So hopefully in the next couple months, once we get the website updated, that'll be available too. So this is just another plug for our Congress that we had, and a whole variety of techniques there that were covered in Panama City at that lecture session and membership or Congress. There's a bunch of memberships that are available, student and individual, and then we have a whole bunch of partner nurse anesthesia associations that help contribute to the group as well. And then if you got any questions, even after the lecture, you can feel free to send me an email there. I'll be happy to get them answered and get that. But this is the eagle eye view of where I made the practice change in our 1 OR in Iowa. So this is what the setup looked like and tools I had at my disposal to get that done. So with that said, let's see, questions. Elizabeth also asked, how less successful is opioid-free anesthesia without a regional block? It can be done. One of my good friends, Derek Galvin, he works out in North Carolina. He was one of the first in the country to apply these techniques to cardiac surgery. So traditionally, cardiac surgery is, heavy-handed, narcotic-based. Patients having heart surgery are typically getting 40, 60, 80 cc's of fentanyl during a typical cardiac case. And he was actually able to apply these techniques, and without regional blocks was doing opioid-free cardiac cases. He was just very judicious in his titration with mag and lidocaine and ketamine and Precedex, and then the pre-meds. And that practice that he started doing that at, now all the other anesthesia providers have adopted that because the patients are just doing so much better post-operatively from their cardiac surgery. So with that said, it is possible to do opioid-free anesthesia. You got to be much more purposeful with it. It's much more difficult. The regional blocks that we add to that basically make doing opioid-free anesthesia a chip shot. Usually I get a question like this, and so I was just looking. So this week in the OR, I did 3 total knees, 3 colonoscopies, a biceps tendon, an umbilical hernia, EGD, a total mastectomy, 3 knee scopes, carpal tunnel, and a trigger finger. That was my caseload for the past 5 days, and not a single nanogram of narcotic did I have to give for any of those. So it is absolutely doable. It just takes effort and purposeful selection and anesthesia practice to be able to accomplish that. So the one thing with you guys being most PACU focused is those that are doing opioid-free anesthesia typically are heavily reliant on you guys, because you guys are the ones that, if they do need a narcotic, opiate analgesic, are the ones making the initial titration. I just want to let you know that if anybody you got in anesthesia that's dropping you off of patients doing that, you can typically go with about half the dose you'd normally give and see a much more significant, profound effect in the analgesic if you do have to give an opiate in the recovery room, because those are much more effective because that mu receptor hasn't been hammered during the whole anesthesia. So with everything else topped up and loaded up with the multimodal, you get a much more effective pain relief from a much smaller dose than you would typically see. So does that answer your question, Elizabeth? Okay, perfect. I just want to make sure it's clear in my head, but sometimes getting the message out coherently is a problem. So I just wanted to give you guys a chance for any more questions before I sign off and hand this back over to Diane. Anybody? All right. And Diane, great. I'll send you the email with those 2 articles to send out a little bit later.
That's great. Thank you so much. I learned a lot.
I appreciate it. It's something that's becoming more and more passionate about. And now that I'm seeing this, it's just totally changed some of the things we do. Like the mastectomies at our hospital used to be a 1 to 2 day admission for post-op pain control and nausea and vomiting control. The total mastectomy we did with the blocks and the opioid free, she was discharged 60 minutes after waking up in recovery.
I know. It's good to look at it from a different point of view, for sure.
Yeah.
Great.
So
thank you so much.
You bet. Let's see. I just want to make sure I didn't have any other questions. Jonathan asked, how can nurses support CRNA in making this transition? First thing I would do is just get them exposed to the idea. Even probably 90+% of my colleagues don't even know this is a thing yet. So just getting them exposed to it and having them network with some other CRNA colleagues is definitely something that would get them at least started down the right road and get them at least open to the idea of it. So.
All right.
All right.
Very good.
Thanks, guys.
Thank you.
Have a great rest of your meeting.
Thanks. Take care now.
You do.
Thank you. Good morning.
Good morning.
Hi, Dr. Lee.
How are you?
I'm good. How are you? Thank you for coming.
Good.
I just wanted to let you know also that we are recording because there are people who couldn't make it this morning, but who would like to see it later. So just wanted to let you know.
That's perfect.
Thank you very much. Laura will do the introductions.
Thanks.
You're welcome. Laura, you have to unmute yourself.
Sorry, got a little overexcited, guys. So before we have Dr. Lee come on, one quick housekeeping thing. Please check your emails. The evaluation form should have been sent out to you. We do ask that those are completed, so you do get your CEU credit for that, and just send them back to me via email. You can scan them. It doesn't matter how you do it as long as it's completed and it's got your name on it someplace. If you don't have a name on it, I can't issue you credit, guys. So without further ado, we have the lovely Dr. Lee. She graduated from McGill University of Medicine in Montreal, Canada in 2007. She received her PhD from molecular and cellular biology from University of Buffalo in 2002. She received her MSc of immunology from Capital University of Medical Sciences in Beijing in 1997, and received her BS in advanced nursing from Beijing University from Beijing, China in 1993. She is board certified in focused assessed transthoracic echocardiography. She's a diplomat for the American Board of Anesthesiologists. She is a fellow for the American Society of Anesthesiologists. She is a Yale School of Medicine's Medical Educational Fellowship. She's been a featured speaker for the American Society of Anesthesiologists, the Chinese Association of Anesthesiologists, the Serbian Association of Anesthesiologists, Intensivists, and European Society of Anesthesiologists, and the American Society of Regional Anesthesia and Pain Medicine. She has been published in multiple peer-reviewed manuscripts and has served as editor as well. And right now, her current position is Director of Regional Anesthesia and Acute Pain Medicine at Yale University and Yale New Haven Hospital, and she's also an associate professor there as well. Without further ado, I'd like to introduce Dr. Lee.
Thanks much, Laura, and good morning. It was such a pleasure to meet everyone. Such a pleasure to be invited to come to your meeting. And I would like to take these opportunities to introduce some of our perspectives, and hopefully we can promote further collaborations. All right, so I'm sharing screen, and if you don't see it, please shout out to me, and Dan has my cell phone, just text me or call me. So today I want to talk about the perioperative nursing perspectives for nerve block patients. What are the rationales, implications, and the must-knows? I have nothing to disclose. And so I was started with nursing responsibilities for nerve block patients at different stages of palliative care. The routines applies to our regional anesthesia. And then I'll follow with the specific implications for specific upper, lower extremity and truncal blocks. At the end, I'm actually asking the audience for if you have any suggestions to promote further collaborations. I think perioperatively anesthesia and nursing are the most two important workhorse over there. So for those of you who work at Yale and probably other places, the same thing for regional anesthesia, we just have too many consents. We have the surgical consent, we have the OR anesthesia consent, we have the block consent. And for the nurses who work at Yale, many times I actually feel sorry they chase down for the surgical consent. in order for us to do the nerve block. So why do we even need the surgical consent? Well, there are situations the patients change their mind the last minute, refuse the surgery, or the surgeon have some additional information coming up with the change of surgical plan. Sometimes the patients on both extremities needs to have surgery, but they, for whatever reason, one side need to go first. So those informations all need to be clear before we can perform the nerve block. Now, some probably say, what is the downside about a few, let's say a handful of unnecessary blocks versus all the trouble our nurses have early in the morning, have to chase down all the surgical blocks? I don't know. I don't know at this moment, but what I'm thinking is we're working on electronic consents, and that may be solving the problem. At this moment, the surgical consent is probably, I will say, anywhere between 10 to 20% of the time, causing a lot of turbulence in the process of doing the nerve blocks. Why we do an anesthesia consent? Actually, when our block attending come over to see the patient, we actually do a full review of the history, and we do a very relevant physical exam. So first, we want to rule out if the patient have any contraindications for OR anesthesia, if the patient had a recent heart attack, needs an echo, needs a cardiology clearance, if the patient 2 days ago went to ED for asthma exacerbation, and nobody is going to induce general anesthesia in this patient. So that's one of the reasons we actually consent the patient. So we have an anesthesia consent, we have a block consent. When it specifically comes to the block consent, we need to give the patient choice. Even though we want them to go opioids, we think it's beneficial for them, at least at this stage, they have to be the one to make a choice. So we have to offer them with alternatives, even though we don't like the opioids. And we also need to let the patient know what to expect, the block onset, risks, benefits, how long can last, what does it mean when the block is going to wear off, how are you going to feel, and how are you going to make the transition from block wearing off to the oral medications. And you and I have already seen a couple of patients each year, they will go to emergency room when the block wear off. And that's probably we did not plan the block well enough, and we actually did not warn the patient enough. And the studies shows the reasons patients refuse general anesthesia. Number one is when they had a past experience when the block wear off, the pain was even worse. They need to go to the emergency room next time coming back. They don't want the block. And certain percent of patients are very frustrated with a dead arm, dead leg, and the trips, falls, causing repeat surgeries. That's something they don't want. And the fall risk is actually does not only apply to lower extremity blocks. Upper extremity blocks actually cause balance issues as well, especially with elderly patients. And recently, we've been doing is sending the patients with on-cue pumps. And for those working in the McGivney Center, probably very familiar with the materials. We send the patient home with the on-cue pumps in terms what to expect, how fast the pump should deflate itself, and what do you do when the pump completely collapse, and how do you remove the catheters, who to call, when to call in terms of have any questions. One thing to remember is it almost never have any urinary retentions associated with the peripheral nerve blocks. Now, in terms of consent, we all had those situations without patient. If the patient receive, say, 100 mg of fentanyl, and then becomes a major issue, oh my goodness, the patient's got fentanyl, now it's sedated, how the patient's ever going to send the surgical consent, do we have to cancel the surgery? Now, here's the thing, we have to think a little bit, step back, think a little bit differently from the inpatients. Now, think about our inpatients. They're all on opioids, and many of them are benzodiazepines. And many times, we are having them signing consents, and we consider those are legit. So bottom line is really not what medications we received, whether or not they can sign the consent, they have the informative consent for that purpose. It's more so about the mental status. It's not about 100 microfentanyl that patient cannot sign the consent. It's about a 50 microfentanyl patient go into a state that almost like coma, is no longer responsive. So all our block patients, we need the monitors, and we also need a nasal cannula oxygen. This is routine mandated by American Society of Anesthesiologists and American Society of Regional Anesthesia. Now, many probably think that's because we're going to give fentanyl, Versed, even Presidex, some even give propofol for the block. But many of those, for us who work at ISRC, we really don't give that much sedation. So can we get away from the monitors or the oxygens? Those are actually only partially, and a small percentage of reasons are actually for sedation. The major reason is for emergency detections and management. And mostly it's just for local anesthetic systemic toxicity. For that, we use the monitors to monitor the changes on cardiac conditions, CNS conditions, and if local anesthetic systemic toxicity did happen, actually the patients have a better oxygen conditions, less acidosis, makes patients more responsive to intralipid resuscitation. So in terms of the sedation for blocks, many probably ask, do we really need it? Well, probably not if you really go to the bottom of it. The block procedures we do are much less painful than those procedures they do in the office, such as facet joint injections, epidural steroid injections, much, much less. We use the max needle we use is like a 20 gauge needle. Many times it's 21, 22, even 25 gauge needle. In reality, we don't need it. Why do we do it? We do it is because benzodiazepines can increase the seizure threshold. So that's one of the reasons for patient safety. And the other is increase the patient comfort satisfactions. It is really not because it's so painful, it's really make patients more comfortable and more receptive to this procedure. Now, can we deviate from this? Well, if we deviate from this, can we get away from the request for surgeon consent before we do the procedures? It's not necessarily unethical or not possible. But nationally, most places, we don't do it that way. And if you want to do it, you need to have the surgeons, anesthesiologists, nurses, and patients on the same page. Do we really need an IV for nerve block? Well, one reason is for sedation. But most importantly, it's actually for emergencies. During emergencies, we have some ways to give patients medications for resuscitation purpose. So as a nurse, when you check in the patients before we do the nerve blocks, what should you particularly pay attention to? So first, you pay attention to patient have no contraindications for surgery. That includes if the patient's going home the same day, then somebody is going home with him and staying with him. There's any hemodynamic stabilities, coagulopathies for regional anesthesia, such as spinal. Diabetic patients, we need to check serum glucose or finger stick. And the female patients, we do check the pregnancy test, childbearing age. We also make sure patients have no contraindications to intraop anesthesia, not only just the NPO status, but also anticoagulants for spinal anesthesia. Does the patient have any recent ED visit, recent hospitalizations? And is there any recent cardiac issues, breathing issues, COVID, vaccine within a few weeks? Those are all the concerns. And make sure patients have no contraindications for regional anesthesia. If the patient has severe existing neurological deficits, coagulopathies are very important to know about. During the nerve block, as a nurse, will be very helpful to monitor the patient mental status, respiratory status, and O2 saturations. There were once we had the patients very sweet when we consent the patient, yeah, sure, that's great. I don't want opioids. Come on, bring in the block. But during the procedure, patient becomes increasingly not cooperative, combative, not following commands. At this moment, we probably, well, there's some things we can think, oh, maybe patient's very anxious, maybe need more sedation. But on the other hand, probably we should also think about, is this the CNS excitation? Signs and symptoms from the local anesthetic systemic toxicity. And sometimes when we do the nerve blocks, especially when we're doing it with a fellow, with a resident, with a trainee, then we focus on those perspectives, and the nurse will be very, very important to help us monitor those status. So typically with the local anesthetic systemic toxicity, the first thing patient probably tell you, I feel like my mouth is numb, or some ringings in your ear, or feel like started getting excited, just like we just talked about. And the next thing you know, patient becomes less responsive, seizure. And from the cardiac perspective, you may start to see the heart rate suddenly start to shoot up and blood pressure started to keep going up. That could be because of anxiety, but more likely probably coming from local toxicity. It never hurts just to speak up, hey, the heart rate is up, the blood pressure is up. Is there something wrong over there? Of course, when that happens, we need to really start the treatment with the intralipid, give oxygen, control the airway, because we do not want this go into cardiovascular depression. If that happens, then the patient will need to go on bypass. And many facilities, especially the nerve block is being performed in ambulatory surgical center, you don't have access to bypass instantly, and that can cost patients' life. So after the block team, like the anesthesiologist did one block, they move on to the next block. As a nurse, what should you monitor the patients if anything goes wrong? What will be the alarming signs that you think, I need to get the anesthesiologist back. I don't think this is right. We talk about the mental status change, either patients become excited or patient becomes less responsive, comatose, or becomes more sedated. And then we talk about the CNS excitations, depressions, and the cardiovascular system excitations, depressions. And the other thing that patient probably will ask you, oh, I don't think the block is working because I'm still moving your fingers. So the onset of the nerve blocks, there's an order of that. Pain control is probably one of the first ones, the second one actually. Sympathectomy is the first one to come in. So if you do a neurexia, the first thing you notice is your blood pressure going down. But with the peripheral nerve blocks, the first thing that takes effect is actually pain control. And the next, the patient started to feel numbness, tingling sensations, all the paresthesias. Motor block comes really the last. Upper extremities, it will take anywhere between 5 to 15 minutes, 30 minutes to be fully blocked in terms of motor block. Lower extremities for sciatic nerve block, at least a half an hour. Before that, the patient is going to just move toes freely, and that has nothing to do if the block is working or not. Right after we finish the sciatic nerve block, if you bring the patient into the room, if you do the surgery, the patient's not going to feel pain, but patient is going to move the toes. And if they move the toes, sometimes they don't even know they're moving the toes. And upper extremity, you notice that we have the slings around the arm, and the post-surgery, they have the slings just because they have no sensations whatsoever. We don't want them to use the blocked arm to do anything, for example, rubbing their eyes, because the numbed arm is not going to have a very, very accurate positioning in terms of the eye locations, can cause injuries. And we talk about the fall risk, that's not only for lower extremity blocks, also for upper extremity blocks. So when you work in the recovery room and the patient had a block, what should you pay attention to? Now, before we go in that, let's look at a different type of blocks. Let's start with the most effective blocks that was spinal anesthesia, nothing beats spinal. And then we're going down to the surgeon's local infiltrations. Obviously, nothing comes without a price. The most effective blocks are also more likely associated with sympathectomies, mortar blocks, and more likely associated with phenodynamic instabilities. And if anything goes wrong, the complication is much more severe. So we started with the spinal anesthesia, epidural anesthesia, followed by plexus and paravertebral blocks. And those are the blocks we block as the spinal nerves just leaves the spinal cord and they form a plexus. And typical plexus block we see is the brachial plexus block for upper extremity, lower extremity, lumbar plexus block, a paravertebral block, and sacral plexus block for the lower extremity as well. Individual nerve blocks, for example, lower extremity, we have the femoral nerve blocks, popliteal sciatic nerve blocks, proximal gluteal sciatic nerve blocks. Many truncal blocks that includes erector spinae blocks, quadratus lumborum blocks, TAP blocks, so on and so forth. And the last one will be the surgeon's infiltration. So we talk about not every block is created equal. When you are in the recovery room, when you are receiving patients, it was very important for you to know for what block patients you should expect complete analgesia. And if those patients have any pain, you need to talk to the anesthesiologist who did the block. And there are certain other blocks, incomplete analgesia is the goal. So if you have any pains, then you can go ahead to treat with opioids or non-opioid analgesics, whatever being ordered. So those you should expect complete analgesia. That includes your clavicle procedures, any upper extremity procedures from shoulder down to finger, any ankle procedures, and then knee procedures like the ligamental surgeries such as the ACLs, meniscus. The incomplete analgesias, some of those not because we cannot do, it's because the patient needs physical therapy right away, such as the total knee, such as the hip procedures. And most of the truncal procedures, they probably need a little bit of opioids here and there. If they don't need it, kudos to the anesthesiologist. But if they need some, it is expected. So when you look at the pain in the recovery room, a couple of things is very important when you want to talk to us who did the block in terms of patients having pain. Is it a surgical site pain or non-surgical site? Is it a tourniquet pain? Is it a referral pain from laparoscopic procedures? And is it positional pain? For example, for robotic mitral valve repair, the incision is all in the front, but the patient is complaining about the scapular pain. It's actually because patients are ipsilateral position for hours and the patient's literally resting the body weight on the scapula. The chest tube pain, and of course, the compartment syndromes are the other concern as well. So the more details you have on the pain, and then the more it will be helpful for the anesthesiologist to solve the problem. Where is the worst pain? It is new. Is it similar as patient had a pre-op, or is different? Does it radiate? Is it a constant pain, or is it spasmodic pain? And is it getting better, getting worse? It is responsive to medication. And it's very important, we should know for particular type of procedure, complete analgesia or incomplete analgesia is expected. So sometimes there are some blocks that's truly failed. It's a failed block, it needs to be repeated, and you should contact anesthesiologist as soon as possible, even before you give opioids. And there are some other blocks, it looks failed, but it will never give you complete analgesia. Post discharge. Typically, we should follow up the patients. We follow up the patients, but I know routinely you follow up the patients as well. So it's very, very important to ask for the motor block, because at the end of the day, it's the functional outcome. If the patient cannot move extremities, cannot ambulate, had a fall, went to the ED, those are very important and we want to hear about it. Sensory durations, how long the block lasts, do patients still have any numbness here and there? Is the numbness getting less, getting more? And how did the patient handle from the transition from the block to oral analgesics? If the patient went to the emergency room for pain control, even with hospital admission, we appreciate you give us feedback. For patient who goes home with on-cue pump, pay attention to leakage, especially pay attention to if any signs of infections. Does patient have any fevers, chills, those kind of things? Bottom line, we want to make sure patients returning to baseline on the way at least. And we pay attention to side effects from opioids. Is patient overly sedated? Is patient taking too much? Well, the $1 million question is, what's the best time to call? Well, we should call them the next day, because those are the times this condition changes the most. But be aware, when you call them the next day or 2 days later, you're not going to get all the story. For example, the patient say, oh, no, I don't have any paresthesia. Now, do you really believe patient does not have any paresthesia? Patients having pain. And this is a dominant concern for the patient. Patients feeling the pain more than anything else. Now, if you call the patients in 1 month, in 3 months, then they will tell you, you know what, after my shoulder procedure, I just have like that patch of numbness on my deltoid, very small, but it's getting less. So if any nurses, you have nursing students or somebody who is interested in a research project for long-term follow-up, I'm actually looking for someone to collaborate with me. So this is typically what we're doing blocks nowadays. We have a block card and we have all the standard monitors, and typically ultrasound is almost a necessity in terminal blocks. And that's not only for a fancy purpose, actually, there's a safety reasons behind that. So in terms of complications from nerve blocks, if you look at the literature, there's many publications. But what we want to look at are those under ultrasound guidance. Those will be the most relevant. So this study coming from Dr. Brian Saiz, he is the editor for Regional Anesthesia Acute Pain Medicine. It's really the most important journal for our subspecialty. So he used 8 years. He followed up 22,000 patients. And he found there's 0.06% patients. When we do the nerve block, we can have unintended venous puncture. And 0.12%, we have unintended arterial puncture. 0.008% of patients, we may have a seizure, and there has been no cardiac arrest. Now you look at this, you say, oh, 0.06% for venous puncture and 0.12% for arterial puncture. Does that mean it's much more likely, almost double the chance for us to puncture the artery than the vein? Now remember, this is a prospective clinical registry. So it has a couple prerequisites for this to happen. Number one, the clinician need to notice what happened. And number two, the clinician need to report it. So when you look at this artery, even though when they're very small, we can still see it. And if we puncture it, we're going to see blood come back when we aspirate, even when we don't aspirate. Well, the very small venous structures are different. Especially when we put the ultrasound probe on it, we aspirate, it's negative. But when we inject, it is called intravenous injection. So those are more from report bias rather than just the reality. So we talk about the typically with the nerve blocks, we are under ultrasound guidance. Ultrasound guidance improve the quality of blocks. We can use less amount of local anesthetics. The blocks are more effective, faster onset, much stronger blocks. But bottom line, when it comes to patient safety, is to decrease the local anesthetic systemic toxicity. This is a study coming from Australia, and they look at nearly 500 patients with all type of blocks, upper, lower extremity with different local anesthetics, ropivacaine, lidocaine, and then about 500 patients without ultrasound and about 20,000 patients with ultrasound. Their incidence of local toxicity is about the same. Both have around 10 events. So this tells us ultrasound decreased the chance of local anesthetic systemic toxicity by 80%. And this is really probably the strongest data ever to advocate the use of ultrasound for peripheral nerve blocks. And this is published by Ezra in terms of the, what should you do when there's a suspected or confirmed local anesthetic systemic toxicity. We actually have printed this out, laminated, and put it attached into our ultrasound machine. So intralipid is the most important resuscitation medication for local anesthetic systemic toxicity, in addition to airway management. Epinephrine, it's not to say never ever use it, but it should be saved for the last step and should be very low dose, like a 1 mg per kilo. Vasopressin is contraindicated. And of course, any additional local anesthetics or beta blockers, calcium blockers are contraindicated. The next thing we typically worried about when we do nerve blocks is nerve injuries. So with the same study, physicians reported about 0.2% of the patients will report paresthesia when we do the nerve block. And 0.18 patients after the surgery, after 5 days, will still have some neurological symptoms. Those can be sensory, can be motor. And 6 months after the nerve block, 0.09% of patients still have some neurological symptoms. And those again can be sensory, can be motor. But remember, this is a prospective clinical registry. So we do not know those temporary or permanent neurological deficits are coming from existing injury before the surgery, because we did not document the baseline. It's from intraoperative positioning, intraop surgery, or the nerve block. So all the factors are mingled together. Not trying to point fingers to everyone, just a couple procedures we know it is inherently associated with high-risk surgery. For example, if you look at the shoulder procedure, the axillary nerve, the suprascapular nerve is right in the surgical field. It's, as a matter of fact, those are not only the 2 nerves that are reported being injured during the surgery for shoulder procedures. Nearly every single nerve from the brachial plexus, even the ulnar nerve, so far down below away from the surgical field, can be injured due to shoulder procedure just because the brachial plexus is so close to the surgical field. And let's look at the elbow procedure. Many surgeons actually don't like blocks for elbow procedures. There's a reason for that. When we look at the lateral view, A is your radial nerve, and the 1, 2, 3 are where the surgeons put the pores in, very close to the nerve. And then there's a medial side. A is your median nerve, and C is your ulnar nerve. and 1 and 2 are the port size, and B is the medial antebrachial cutaneous nerve. So you can see the surgical port, the surgical field are very close to many nerves for the elbow, not just the traditional textbook teach us all the nerves. The radial nerve is right there, the median nerve is right there. So there's a reason many surgeons don't want us nerve blocks for the elbow procedures, or they want it postoperatively. Now there's a problem for postoperative nerve block as well. When the patient's in recovery room screaming with pain, and you say, can you move your fingers? Can you feel me touching you? And they say, yeah, just give me that block. Those are really just very, very gross neurological exams. When the patient having that much pain, the neurological exam should be not considered that accurate. We can only say that patient does not have gross neurological deficits. So what will be the contraindications for nerve blocks? Typically nowadays, we typically don't talk the patients into the nerve block purely for pain control reasons. Typically, we'll talk them into nerve blocks for cases like AV fistula. You really should have it because the high risk vaginal anesthesia, or the patient have a rib fracture. If you don't do the nerve block, you may stay in the ICU with the endotracheal tube forever if you ever even get out of the ICU. So those are the situations actually I do try to twist it a little bit and really try to persuade the patients into having the nerve blocks. But all the others, really, we try to give patients a very honest, complete picture. This is the benefit we can offer, but you can always have morphine, you can always have Percocet, and it's ultimately is the patient's choice. Even though we all like it opioid free, but we cannot make decisions for the patients. And there are contraindications for surgical reasons. For example, we talk about the elbow surgeries. Typically, the surgeons would like to take the nerve before the surgery, intraoperatively and postoperatively. And contraindications because of anesthesia reasons, because if the patients, for example, have ipsilateral diaphragm palsy already, then intrascaling block is going to be contraindicated. Coagulopathies, there's risk of compartment syndromes, existing neuropathies. Many of those we wouldn't consider absolute contraindications. We have to talk about on a case-to-case basis. For example, many of the AV fistula patients, they are on Plavix, there are some coagulopathies, but the benefits is really outweigh the risk. We'll still do the nerve block. When the patient have existing neurological deficits, do we do nerve blocks? Depends. If the risk is much, much higher than the benefits, we will not do it. But if the benefits significantly outweigh risk, we'll do it and we'll modify our techniques. We use reduced dose of medications, we decrease the concentration, we use low potency local anesthetics. And if we use a short acting, it's possible, and we don't use any additives to make the picture more complex. Typically, before we do the nerve block, we really need to do a timeout. We basically identify the patients with 2 criteria. So make sure the surgical consent match what we have in the computer, match up with our nerve block consent. And even with that, once every couple of years, we will still have the wrong-sided block, which is really bad. So what do we do during the block procedure? We watch all the monitors and we watch the patients. We keep the patients engaged. We talk a lot of things, seems not relevant. It's really just to keep the patient engaged and monitor their mental status. And also pay attention if they have any injectional pain, they have any paresthesia, and their sedation levels. If we use a nerve stimulator, we'll watch the numbers, typically less than 0.5 and almost never less than 0.2 milliamps. And with ultrasound, we not only observe where the needle is, we also watch where the local anesthetic goes. Technically speaking, if we inject half cc of local, we should see it in the ultrasound. If we don't see it, there's a problem. And we also feel the injection pressures. When we inject, if there's a lot of pressures, then, well, first we maybe is performing an intraneural injection, which is really not good. And the second one, maybe we're injecting into fibrous tissues, so we'll need to redirect the needle. And for those of you who know, we use a specialized needle. It's different than the intravenous needle that's sharp. And this one is like short bevel, it's down. So we use a down needle is because if we move slowly, even when the nerve block needle is close to the nerve is a round structure. The down needle will push the nerve away rather than puncture the needle. That's another safety measures we take. Post procedures, just like you guys follow the patients, we follow the patients as well. We follow the patients for motor block, for analgesia block, for sensory block, and we document until all the neurological deficits are completely resolved. And if any concerns, we actually order EMG study as soon as possible, as needed, sometimes even MRI studies, nerve conduction studies. If by 12 weeks, there's still no complete improvement, and the surgical explorations will be needed. And as I said, I really appreciate the feedbacks during your phone calls, your tongue contact with your patients. If you ever hear anything, all anesthesiologists will be very appreciative if you give the feedback to them. So next, I'm just going to discuss a few things I found it over the years that's kind of important for us to communicate with each other in terms of specifics for nerve blocks. So for the upper extremity, it's mostly coming from the brachial plexus. By brachial plexus, we mean it's coming from the nerve roots C5 to T1. So right after nerve roots, they becomes the trunk and becomes divisions and roots and becomes nerves, individual nerves. And we can block them at different locations. That becomes a different approaches of the brachial plexus blocks. For example, this is called the interscalene, and this is called the upper trunk block. This is called the supraclavicular. This is the infraclavicular, and this become axillary nerve block. Now, for the interscalene blocks, there's a reason we worry about the patient's breathing, because if you look at the picture, the phrenic nerve is right next to the interscalene block. The needle typically coming from the lateral side, and this is where we inject, and this will be where the phrenic nerve. From an anatomist's perspective, 100% ipsilateral phrenic nerve will be involved. Whether or not the patient is symptomatic has a lot to do with patient's baseline conditions, comorbidities, also with the volume we use and the speed we use to inject. Supraclavicular is going downward on the first rib, and we do this block many more times the interscalene, because interscalene we mostly do it for shoulder procedures, and then supraclavicular we use it for the whole upper extremities. The reason I want to point out, this is the lung and this is the pleura. So there's a small risk the blocks can cause pneumothorax. With ultrasound, the risk is nearly zero. Before ultrasound, this block is not even possible because of a high risk of pneumothorax, because you can see pleura is so close. Many times we talk about the interscalene block has 100% phrenic involvement and 70% complete ipsilateral diaphragm palsy. So we started to do something called the superior trunk brachial plexus block. It's basically a block halfway between interscalene and supraclavicular. It has about a 5% chance of complete hyemate diaphragm paralysis. And you will see more and more, we're going to talk about this block in clinical practice. Axillary nerve block is basically with the patient's arm out, it's performed in the axillary region. This block was used very frequently before ultrasound time because you can actually go through and through. You can feel the axillary artery. Now with ultrasound, this is much less frequently to be performed just because it's #1 reason, actually maybe top 10 reason for peripheral nerve blocks to have local anesthetic systemic toxicity. The reason being, we know the vessels travel with the nerves. At this stage, the nerves already comes individual nerves, your radial nerve, your median nerve, your ulnar nerve. You also have a lot of bifurcations for the arteries, for the small veins. It's just very, very high risk for intravascular injection. And the other things needs to pay attention to is this is muscular cutaneous nerve. At this stage of brachial plexus, this nerve already left the rest of the brachial plexus. So this nerve needs to be blocked individually. Otherwise, you cause a incomplete analgesia on the lateral side of the forearm. This is the part that actually I want to bring it to your attention, and I don't want you to think it is okay to take it as patient having pain, any upper extremity procedure. If they have pain in the axilla, this area, you should go to your anesthesiologist, tell them to do something rather than you just give opioids. This part is not covered by brachial plexus. So not everybody does the block for this part, but they should do it. And if you remind them, they will do it. If you don't remind them, they sort of forget about they need to do it. And you just manage those pains with opioids. And they think, oh, those patients don't really have pain over there. They don't really need to add on additional block. There's a couple ways of blocking this area. We can do an intercostal nerve block. We can do a PACU. We can do an intercostal brachial block. Many ways to do it. Surgeries such as reverse shoulder replacement, bicep tenodesis, rotator cuff repair, and tourniquet pain, elbow procedures, AV fistula, you name it, many of them will have pain over there. So if you have a patient, they had an upper extremity procedure and they did a block, you should expect complete block. Never take an incomplete block for upper extremity procedure. If they're having pain, you need to reach out to your anesthesiologist. They can simply do a simple block, supplement, and spare the patients of all the unnecessary opioids. If the patient paid for the bill for nerve block and they did not have a complete analgesia, that's not good patient care. And that will be your role and our role, and the communication between you and us will be very important. Lower extremity. Femoral nerve block is very typically used. We inject, this is the femoral nerve, lateral to the femoral artery and the femoral vein. Is very easy to perform. On the other hand, we don't use it as often nowadays because of the early recovery, early physical therapy. So only most of the time it's actually just used for hip fracture patients because you just cannot move them. There's nothing else you can do. Instead, for the knee procedures, ankle procedures, we're doing the adductor canal blocks. Anatomy wise is very different. We inject local numbing medications next to the superficial femoral artery where you have the saphenous nerve and nerves for vas medialis. Very good analgesic effects for medial side of the lower extremity. The major nerve for ankle procedures, any procedures below the knee, will be the sciatic nerve block. Along the path of sciatic nerve, popliteal fossa area will be the part of the sciatic nerve that's closest to the superficial part, so it's easy to do. You can have the patient prone, left lateral, right lateral, or supine, any position you want. And you can see the tibial nerve and the common peroneal nerve, they're casing each other. This will be the perfect location to perform this nerve block. Like we said, ankle procedures, you should accept complete analgesia. Any patients have any pain except tourniquet pain, you should reach out to your anesthesiologist. For BKA patients, we can still get away from adductor canal block and popliteal sciatic nerve block. But when it comes to AKA, we'll need to do transgluteal sciatic, will be much higher. Until ultrasound guidance, you see the greater trochanter, atrial tuberosity, you have the gluteal maximum, you have the quadratus femoris, and right between is your sciatic nerve block. And the curvilinear probe is a little bit deep, but with nerve stimulant assistance, it's very much doable. If in your hospital, your anesthesiologists haven't started to do lateral pharmacutaneous nerve blocks, you can ask them, because this is a very superficial, simple nerve block. We do it outside of the groin area, between the sartorius and tensor fascia lata. I've almost never seen a nerve that is deeper than 2 centimeters. 5 cc is sufficient, works great for hip procedures. If you look at the dermatomes, this can be the distribution of your lateral pharmacutaneous. This is the front, can goes to eyes to half of your front of the thigh, and of course the lateral side of the thigh. It's a large area and it's a small nerve, it's sensory only, nearly no risk, so you should ask your anesthesiologist to do it. Obturator nerve blocks is also very simple. We injected between the adductor, above the adductor brevis and below adductor brevis, between the adductor longus and the adductor magnus. And the ultrasound is very simple, can be used as a supplement for any knee procedures. For example, we routinely use this for our ACL procedures to achieve complete analgesia. The proximal obturator nerve block is used for the hip procedures, and you inject it between your pectineus muscle, obturator actinus. It's a fascia plane block. It can be used as a rescue block for the hip procedures if after the surgery your patients complains just the inguinal area pain. Next, we'll talk a little bit about the chest abdominal procedures. Type blocks, you've seen it, we do it all the time. It's probably, I will argue, the most commonly used peripheral nerve block techniques, simple to use, effective. And you basically inject it between internal obliques muscles and transverse abdominis, and you want to separate those 2 layers. Typically, we are moving away from type blocks at Yale New Haven Hospital just because we have better options called quadratus lumborum block. And this is your 3 layers, external oblique, internal oblique, transverse abdominis, but we started to do quadratus lumborum muscles. The reason we do that is because type block, it gives you only somatic pain control. So what that means, it can numb your skin, can numb your muscle, but any deep inside the visceral pain, forget about it. With the quadratus lumborum muscle, we not only cover the skin pain, but we also cover the visceral pain. Now, considering a patient, or if we're the patient, we have a surgery, which one will you choose? If we coming to see you, we touch your skin, say, oh, do you feel it? No, it's numb. Okay, take a deep breath from me. Oh, that is not a good block. That's not the typical block we want to use. We want to use to see the kind of block is quadratus lumbar block. When I go to see the patient, say, how is your breathing? Okay, doc, let me practice a deep breathing for you. If you hear the voice and the way that they're presenting themselves, you know you're doing a successful block. Ultimately, when we do block, we're talking about the functions. We're not talking about trying to make the skin numb or the muscle numb. Actually, the ideal block is if we can do a nerve block, patient doesn't even feel any numbness, but they feel no pain either. That would be the best block, I will argue. So with the quadratus lumborum block is a deeper block. We use a curvilinear probe. We typically have the patients on the lateral side. For those of nurses at the Yale New Haven Hospital, they know we turn the patients left and then right. It's a deeper block. Like this one is like 9 centimeters, but it's really not hard to do. You identify vertebral body, transverse process, erector spinae muscle, quadratus lumborum muscle, and psoas muscle. So the injections performed between quadratus lumborum and the psoas muscle. With the proper patient positioning, proper ultrasound technique, I can get my CA1 resident to do this block. So it's really not that hard. I think if your hospital haven't even started to do this, you really should do this. Now, paravertebral blocks. What is paravertebral? It's paravertebral, right? So the vertebral part, close to the vertebral body, we do the spinals, epidurals. That's where we're very familiar with. Now, paravertebral is the space between the transverse process. So it's a little bit further away from the central neuraxis. So the effectiveness is a little bit less than that, but it's much better than downstream. The other thing we want to point you to attention is the purple is the flora. So this is probably the biggest risk or the biggest concern for many practitioners for this block is pneumothorax. In experience, the practitioners is probably 0.05% of chance of pneumothorax. It's never zero. And this block can be done blindly with the patient sitting up, or we can do it under ultrasound guidance. We see two of the transverse process. Lung is right here, it's the pleura, it's the costal transverse ligament, and the local numbing medications injected right above the pleura. And you should observe the pleura being pressed down for the best effects. So as you can see, we talk about the truncal blocks. If we perform the block right at the center, where the spinal cord is, that will be our spinal epidural anesthesia. We have the best analgesic effects. There's no question about it. We can get sympathectomy, so we get hemodynamic instability. And if there's any risk of complications, for example, the needle going to spinal cord, you can cause paralysis. As we go lateral, we have the erector spinae block, we have the quadratus lumborum block, and we'll go lateral, we have the type block. So the more lateral you go, the less effectiveness of the nerve block, but the less severe risk of the complications. For the chest part, you guys must have heard the PAC1 block, that's what we use. For the breast procedures, local numbing medications injected between your PAC major, PAC minor, is actually blocking two of the nerves from brachial plexus called the medial lateral pectoral nerve. And PAC2 blocks is we have the local numbing medications injected right on top of the rib. It could be above, could be below the serratus anterior muscle. And this is actually the block we're talking about, give you really good cover of the axilla if your patients did not have a good one. And serratus anterior plane blocks is similar ideas as the PAC2 blocks. What we do is we inject local numbing medications above the rib, below the serratus anterior muscle, or above the serratus anterior muscle, between the serratus anterior muscle and latissimus dorsi muscle. It's a very good block for cardiac procedures, very good block for the breast procedures. Another fascia balloon block, very low risk, and really give us high benefits from this. A very good alternative to spinal, epidural, and paravertebral. We talk about the EST block. What that means is the local numbing medications inject right outside of the transverse process and basically between the transverse process and erector spinae muscle. Very, very good effect, at least for the spine surgeries and some even for the abdominal and chest procedures. We've done good number of blocks for the spine patients, especially for the chronic pain patients. And those patients typically directly go into the ICU, and very good effects for that. So you can see for the chest blocks, it's the similar ideas as what we say for the abdominal blocks. The closer we are to the neuraxial part, the more effects in terms of analgesic efficacies we can see. But also, if anything goes wrong, you're going to see more severe consequences from complications, and you're going to see more hemodynamic instabilities. As you go lateral, go into paravertebral, you still have a little bit of sympathectomy, but much less. We'll see about 25% chance you get a sympathectomy. So you still have some blood pressure drop, not as much as epidural, or definitely not as much as spinal. As you go lateral, you go into erector spinae blocks, quadratus lumborum blocks. The sympathectomy is much, much less. And if you go to type blocks, you should expect no sympathectomy whatsoever. And if you ever see any, that is not because sympathectomy, those blood pressure drop is due to other reasons. For example, that could be local anesthetic systemic toxicity. And we also should understand acute pain management is not only just the blocks. Multimodal analgesia is the way to go, especially for the type of procedures we cannot expect complete analgesia, such as total knee, total hip patients. They get up and walk right away. So acetaminophen, ketamines, NSAIDs, benzodiazepines for muscle relaxants, and flexural muscle relaxants are very important. Now, gabapentinoids. This, we never started to use it at Yale New Haven Hospital because our surgeons had very legit concerns at the start about sedative effects. And increasing evidence is actually advanced against the routine use of gabapentinoids, mostly it's gabapentin, in the ERAS protocol. So nationally, internationally, people are removing gabapentin from ERAS protocol. There's one medication, pregabalin, is actually fairly interesting. There's good data shows it not only effective in pain control post-operative while the patient's in the hospital, but also post-discharge in terms of lower opioid consumptions, lower pain scores, less chance of neuropathic pain. But we haven't really seen ERAS protocols includes pregabalin routinely. That's probably because of insurance issues. It's a fairly expensive drug for the insurance to cover. That's number one. And number two, I will say probably because the nerve blocks, the regional anesthesia techniques are improving, changing, modifying, optimizing any day, you know, as we speak, every other day I turn around, there's a new technique, there's a new block, there's a new cocktail to use. So I will say at this stage, there isn't a need to use gabapentinoids in terms of the acute pain management for at least not routinely in the ERAS protocols. With that, I want to thank you guys again for the invitation, and really a shout out to nurses at the Yale New Haven Hospital, from the leaderships to each individual nurses for their efforts. Without their collaboration, their efforts, our service just cannot be successful. And I really welcome any suggestions, any tips, tricks inside, outside Yale that works really well to speed out the workflow for you guys so that we can provide more blocks for more patients in the environment of understaffing. I will really appreciate. There's so many patient populations I want to, and I have the capacity to do nerve blocks, but because of understaffing, the workflows in the morning, even throughout the day, and my hands are kind of tight at this stage. So any suggestions, really welcome. All right, I'll stop here and I'll take questions. Thank you all. So for gabapentin, all the data from the studies, not only from anesthesia, from surgeon's perspective, they did a lot of studies looking at the impacts of gabapentins. And it looks like in the context of multimodal anesthesia and multimodal analgesia with acetaminophen, with NSAIDs, and with the regional anesthesia, gabapentin did not further improve the efficacy of the ERAS protocol in terms of analgesic perspective, but it does have side effects such as sedation, drowsiness, and this is not something we want to see in the elderlies. So nationally, internationally, there's almost no question. People are removing it from ERAS protocols left and right. You know, monitor end-tidal CO2 is always the best thing. To a certain extent, is almost even more important than the oxygen level. It's a great idea to monitor end-tidal CO2 if we can do it easily without extra cost, extra workload to the nurses. Yeah, then about the PACU assessment, because we rely on you guys to tell us how you feel. And actually, there's a previous question about how you can help to go with opioid free, how you can help to assist us to set out the protocol. I will say now, this is I hope this does not sound offensive, but if you see the attending surgeons, you let them know the patient's having a lot of pain, and this is the second time you pull out your 2 milligram dilaudid, I think that will help, because many times when we as CRNAs with anesthesiologists, especially I do nerve block, I do pain management. So if I go to them to sell my block, almost like I have a conflict of interest, right? But you're the ones front line. You're managing the patients. You're pulling one dilaudid, another dilaudid, left and right. And the attending surgeons need to know. Who knows that? It's the PAs, it's the APRN, it's the poor residents who are up all night, but not the attending surgeons. And if you let them know, and then it will make it much easier. For our nerve blocks, we all do it preoperatively because we have a fairly large volume. For the whole hospital, I will say we have anywhere between 8,000, 9,000, even 10,000 blocks each year. It's just not possible to do it intraoperatively. When the patients are monitored during block placement, we actually are able to connect the monitors, so those vital signs directly linked to the Epic. We start the data collection, and when we stop the data collection, the nurse will pick up from there and continue to monitor patient. In terms of a complete or incomplete analgesic blocks, I will say you suggest talk to your local anesthesiologist because there are some good variations. The list I provided, it applies to Yale New Haven Hospital. Yeah, thanks, Dan. I think I rely on you guys a lot. Like I go to PACU, I talk to you guys. The feedback from you guys are very, very valuable. So don't be afraid, talk to us. If you see any pain, you say, why this patient's having this pain? Is there anything you can do? If we tell you, that there's nothing we can do, the risk is too high in terms of benefit, if we can get the blocks, that's fine, that's the end of it. What's the big deal? But if you don't talk to us, we don't even know those patients having pain, you're giving pain medications. And the first time I started to do blocks for the T1, T2 area for reverse total shoulder, it just happened, I walk in PACU and one of the nurses stopped me and said, hey, Dr. Lee, is there anything you can do? This patient having reverse total shoulder, everything else is good, just excellent having pain. She has had a 7 milligram of IV morphine. Like, this is too much. Let me do something. So feedback from your guys are great. Give us feedback, give the surgeons feedback. I mean, attending surgeons. Well, if you guys have any additional questions, you can find Dan, and Dan can get me at 1 minute, and always reach out if you have any questions.
Thank you very much.
It's a pleasure, Dan.
Great conference. We appreciate that.
We should collaborate more.
Agreed. Thank you.
All right.
All right. Have a
Have a
good
good-
day.
Have a good one. Bye-bye.
Bye-bye. Thank you. All right. Let's see. Anybody have any questions for us? On your evaluation form, please put down any other conferences you'd like to have. There's already been some suggestions that is pain management related. So just email us, message us through Nursing Network. We'll see it. Send us emails. We'll see that. And please complete your evaluation so you get your credits. Okay. All right, Julie, we'll figure that out. Thank you. Great. I know. Do you like the virtual, Judith? Great.
Okay.
It's nice to be in the comfort of your home, having coffee and doing everything you need to do. All right, great. All right, Laura, have anything to add to our conclusion? Oh, you're muted.
I thought I was unmuted. Hang on a
Yeah.
second.
Oh, you are now.
Okay, yes. No, I didn't have too much more to add because I did my spiel earlier. Like Diane said, please be sure to get those evals into me. Julie, I'll look into it. I'll send you a message quick just to confirm that the email I have is correct, but I did send that out probably about 9 o'clock. Yes, you guys can send in your emails, whatever works best for you. You can mail them in, you can fax them, scan them, whichever works best for you. I just ask, please, please, please get them into me before the 28th of May. I go on vacation, so it may be a long time before you get your CEUs if you send them in after that. See, anybody else have any questions that we can help you with?
All right, thanks for the suggestion about once a month. Maybe it's a little bit to put these together because we have to put an application in for the education credits. But if we can have our seminars and somehow figure out an umbrella application for those, we'll ask, we'll check in with CSPAN, who then, checks in with AACN, and we'll see if we can work something like that out. Just little mini seminars would be cool. All right, everybody. If there's no more questions, thank you very much. Thanks to our members. Thanks to people on the board who helped put this on. And we'll try to continue to be a service to membership and to the nurses and PACU nurses in Connecticut. All right, thanks. Laura, anything else?
No, I think that'll do that. And oh, thank goodness you found it, Julie. Okay, cool.
All right, everyone. Have a nice rest of your weekend. Thanks very much.
Will do.
Bye now.